Okay. Right. Hello, good afternoon, guys. Yes, good afternoon, good afternoon. Good evening. Okay, it's afternoon over here, so good evening, good evening. How are you all doing? How's the NEET PG preparation going on? First, am I audible clearly, guys? Visible clearly? Okay, right. So, guys, we'll start with the session of LRR session of anesthesia, right? Left anesthesia to me. Yes, thank you. Thank you for trusting me. I won't break your trust. Not confident. Still, you're having time. Still, you can cope up, right? So, guys, this is regarding the champions exam of INI-CET, which is happening from 23rd to 27th of April. The best thing is the registration is absolutely free. I urge all of you to please register yourself for this exam. Why? Because in this exam, the questions which are prepared are basically the INI-CET high yield images questions, clinical based questions, right? And the explanation for those questions will be, audio explanations will be available to you. Okay. And you can also compare your INI-CET, like your score with other aspirants, right? So guys, I urge you to please join the session, right? And register for champions exam of INI-CET. Okay. Right. How long the session? Will the session be useful for FMG, NEET PG and all? I'll take all those questions, guys. Okay. So first, just look over here. This LRR is not only for NEET PG, guys. It's also for basically for all competitive exams, guys. NEET PG, INI-CET as well as FMGE. Okay. What does this LRR have? It will have some high yield questions. It will have some questions, some high yield topics, and also images. The duration of the session will be 2.5 to 3 hours. Okay. सर FMG के लिए पहले वाला LRR तो चलेगा क्या? चलेगा भाई, ये थोड़ा अपडेटेड है तो ये भी देख लो ना. ठीक है. So guys, we'll be covering most of the session in English only. Why? Because most of the audience will understand English. Those who want some explanation in Hindi, if at all we are having time, you just post your questions. If at all time is there, then I will solve your doubt in Hindi. Okay. So in this session, what are the topics we'll be covering, guys? We'll be covering the most high yield topics such as the pre-anesthetic checkup, local anesthetics, regional anesthesia, general anesthesia, machines, oxygen delivery devices, ventilators, ACLS, monitoring, and miscellaneous. Okay. Starting with the first question, guys. Starting with the first question. A patient comes to you for a PAC. While examining the patient's airway, you see this. Which Mallampati classification this patient belongs to? When he's opening his mouth, you are able to see this. You're able to see this means what, guys? You're able to see the hard palate. You're able to see the soft palate. You're able to see the uvula. You're able to see the tonsillar pillars. Plus, you are able to see the tip of epiglottis. When all these things are visible, this patient belongs to Mallampati class 0. Mallampati class 0, right? Coming into the more details of what is done in airway assessment, what is Mallampati classification, okay? But basically, guys, remember airway assessment is a part of PAC. PAC is pre-anesthetic checkup. In the pre-anesthetic checkup, what are the things that we look for? We look for airway assessment, we look for history, we look for investigation, and we look for fasting status. The most important step in the PAC is always airway assessment. If airway assessment is not done, PAC is not done. Patient can easily die if you don't do airway assessment. Why? Because if you don't do airway assessment, there are much chances that you might fail in intubating the patient. So how will you do airway assessment? Right. Everyone, once again, I'll repeat it. Everyone preparing for FMGE, NEET PG, INI-CET, all can attend this session, guys. Okay? It's important. So look over here. In airway assessment, what we do, We tell the patient two things and we assess for four parameters. We tell the patient to open his mouth. As he is opening mouth, we look for two things. What two things we look for? One is the Mallampati classification. Other is the inter-incisor distance. Okay? That is after opening mouth. Second, we tell the patient to lift his chin. As the patient is lifting his chin, we look for two parameters. What two parameters, guys? The distance between the mentum and the thyroid cartilage, that is called as thyromental distance, and the distance between the mentum and the sternal notch, that is called as sternomental distance. So first we'll discuss about the Mallampati classification. In Mallampati classification, guys, there are four classes. Mallampati class 1, 2, 3 and 4, and there is one more class, that is class 0. Remember, guys, as and as we are remember, class 1 and class 2, these are easy airway. Why? Because you are able to see the structures clearly. What structures, guys? As the patient is opening mouth, you are able to see the hard palate, uvula, tonsillar pillars, all the structures. If you are able to see, that is class 1. Okay. As and as the class is progressing, it goes to class 4. That means what? Only hard palate is visible. That means this patient will be having a difficult airway. Right? So remember, if the structures are clearly visible, it's an easy intubation. If the structures are not clearly visible, that is a case of difficult airway. Now, guys, look over here. Regarding Mallampati classification, Mallampati class 1 means what? There is a mnemonic for Mallampati classification. Class 1 means push. Class 2 is USH. Push means what, guys? In class 1, when the patient opens his mouth, you are able to see the tonsillar pillars. You are able to see the tonsillar pillars. You are able to see the uvula. Uvula means whole of the uvula with the tip. You are able to see the soft palate and you are able to see the hard palate. That is Mallampati class 1. Okay, guys. Next, class 2. Class 2 means what, guys? Class 2 means just remove this P. It will become USH. Meaning what? You will see uvula. But remember, guys, will you see the whole uvula? No. The tip is not visible in class 2. Tip not visible. Okay, you will see soft palate and you will see hard palate. Okay, so that is Mallampati class 2. Apart from that, in Mallampati class 2, tonsillar pillars are visible, but they are visible partially. The tonsillar pillars are visible partially. Then coming to Mallampati class 3. When do you call it as class 3, guys? When SH is visible. What is SH? S stands for when a patient opens his mouth, you are able to see the soft palate and you are able to see the hard palate. Okay, with that you can also see base of uvula. Base of uvula. Okay, and last class 4 means what? Only hard palate visible. That is a case of difficult airway. Then what is Mallampati class 0, guys? Class 0 means all class 1 structures. Class 0 means all class 1 structures plus tip of epiglottis. That is called as Mallampati class 0. That is called as Mallampati class 0. Now, guys, this is regarding what? This is regarding the Mallampati classification. But are we done with the airway assessment? No, we are done with the Mallampati classification. Okay. Next is when you are telling the patient to open his mouth, you look for the inter-incisor distance. It is nothing but the distance between the upper and the lower incisor. Okay. That indicates how easily you can put a laryngoscope. If the patient is having a large inter-incisor distance, you can easily put the laryngoscope. Laryngoscope can easily pass. So remember, guys, some patients will be having low inter-incisor distance. In case of patients who are having low inter-incisor distance, where the mouth opening is restricted, patient is a tobacco chewer, okay, and he is not able to open his mouth and you have to intubate. In those patients, if you want to secure the airway, the best way to secure the airway in a low inter-incisor distance patient is by tracheostomy. Directly, you cannot put the laryngoscope in the mouth. Hence, better is you cut open the trachea and do a tracheostomy. So that's regarding what, guys? That's regarding opening mouth. Next is when you ask the patient to lift his chin, two distances you look for, guys. What two distances you look for? You look for the thyromental distance and you look for the sternomental distance. Normal thyromental distance is how much, guys? Normal thyromental distance is 6.5 centimeters. And what is the normal sternomental distance? Double the thyromental, that is 12.5 to 13 centimeters. 12.5 to 13 centimeters. Okay, guys. So this is regarding what? This is regarding the airway assessment. Now, coming to the next question, guys. Which of the following medications should be stopped before surgery? There are a few medications that needs to be stopped Okay? And there are a few medications that need to be continued without any problem. So what is the medication that needs to be stopped over here? Aspirin, remember guys, aspirin can be easily continued. Normally, aspirin is taken in a dose of 75 milligram that is causing no problem to the patient, that can be continued. Anti-epileptic should be continued. Anti-anginal medication should be continued. The only medication that has to be stopped before surgery in this question is what, guys? Is clopidogrel. Why? Because if you give clopidogrel, there may be chances of much bleeding during surgery, right? So clopidogrel has to be stopped 8 days before surgery. So guys, what are the medications that should be continued before surgery? यानी कि which medications, for which medications you can tell that जैसा चल रहा है वैसा चलने दे, ठीक है? For which medications you should tell that जैसा चल रहा है वैसा चलने दे. Come on guys, what are the medications that can be continued? All active agents always approved. Guys, learn with me only, ठीक है? If I just tell you the medications and all, if I don't tell you how to learn it, then it will be problem. So learn with me only. All active agents always approved. यानी कि all active agents include what? First, antihypertensive medications can be safely continued. They should not be stopped except ACE inhibitors or ARBs. If it is ACE inhibitor or ARBs, you have to stop it on the day of surgery. Otherwise, it will cause profound hypotension during surgery. Okay. Next, anti-lipidemic drugs. Anti-lipidemic drugs means what? Atorvastatin should be continued. Next is what? Anti-anginal medication should be continued. Next is anti-epileptic medication should be continued. Next is anti-thyroid medications or euthyroid medications can be continued. Euthyroid medications can be continued. These are the medications that should be continued before surgery without any problem. Now, what are the medications that has to be stopped before surgery? The medications that need to be stopped before surgery are what, guys? Basically, remember, before taking the patient into the operation theater, you take off the patient's home clothes and you give hospital clothes to the patient. Yes or no? So you have to remember, before surgery, the medication that are stopped are my clothes. For the patient, it will be my clothes. So what medications are need to be stopped before surgery, guys? M stands for what? M stands for monoamine oxidase inhibitors. They has to be stopped before surgery. 3 to 4 weeks before surgery, you have to stop it. Why? Because if you give monoamine oxidase inhibitor, that will basically, if at all you are during anesthesia, you are giving pethidine, it will cause severe sympathetic reaction. Okay. So 3 to 4 weeks before surgery, you need to stop it. C stands for clopidogrel. Clopidogrel also is stopped 8 days before surgery. 8 days before surgery. L stands for lithium. Guys, remember, lithium is stopped 24 to 48 hours prior surgery. Why? Because lithium, if you give to the patient, what will happen? It will prolong the effect of muscle relaxant. Okay. O stands for oral hypoglycemic drugs should be stopped on the day of surgery. On the day of surgery. Okay. O say you can also remember ocipil, but remember, guys, ocipil can be continued for almost most of the surgeries, except if the patient is at risk of developing thromboembolism. Yani if the patient is obese or if the patient is posted for some lower limb surgery where immobilization is there for a longer time, there you need to stop ocipil for 4 weeks. Okay, otherwise continue. Next, T stands for TCA. TCA is tricyclic antidepressants, which has to be stopped 3 weeks prior surgery. H stands for heparin. Heparin has to be stopped 6 hours prior surgery. And S stands for smoking, guys. S stands for smoking. Smoking has to be stopped at least 6 weeks prior surgery. So these are the things that has to be stopped, and these are the things that has to be continued before surgery, right? Now, we are still in the PAC. We are done with the airway assessment. We are done with the drugs. Now we are looking for the fasting status. Normally, we tell the patient to be in a fasting state so that there is no risk of aspiration or there is no risk of Mendelssohn syndrome. Okay. So how many hours of fasting? For an adult, guys, always remember it is said that 8 hours of fasting if he is on solid food. If he is on semi-solid food, then how many hours? 6 hours of fasting, such as khichdi. Okay, the patient is taking khichdi and all, then 6 hours of fasting is needed. But if the patient is taking some liquid means yani ke water, liquid means any juice without pulp is called as liquid. Okay, how many hours of fasting is needed? 2 hours. This 2 hours of fasting is mandatory for adults as well as child who is on liquid. Okay, so adults 862 is there. Next, for child, if the child is on water, then how many hours of fasting, guys? 2 hours of fasting. If the child is on mother's milk, then how many hours of fasting is needed? For mother's milk, 4 hours, and for formula feed, it is 6 hours. For children, you go with 2, 4, 6. Okay, water is same for adults as well as children. Remember, child first drinks mother's milk, then after some time, after 6 months of age, he'll drink formula milk. So in this line, you need to remember mother's milk come first, so 4 hours of fasting, then formula feed is 6 hours of fasting is needed. Okay, next. Next, guys. In ASA classification, a morbidly obese patient with uncontrolled diabetes. Remember, guys, still we are in the PAC. We are doing the last step of PAC. That is nothing but certifying the patient. Okay. In ASA classification, the patient who is morbidly obese and uncontrolled diabetes is categorized as ASA 1, 2, 3, or 4, guys. Come on. A, B, C, D. What's the answer? Very good. Very good. Most of you have given the right answer. That is basically ASA class 3. Why ASA class 3? Why? Because in our case, the patient is having uncontrolled diabetes. Uncontrolled diabetes usually comes under class 3, right? And patient is morbidly obese. Any patient whose BMI is more than 30 or patient having a low ejection fraction comes under ASA class 3. So just we'll brief through this ASA classification, starting with ASA class 1. Remember, guys, ASA is a certificate given to the patient depending upon the systemic illness the patient is suffering with. If the patient does not have any systemic illness, he comes under ASA class 1. If the patient is having systemic illness, which is mild to moderate, or which is under control, is called as, what? ASA class 2. ASA class 2. Yani patient is having diabetes or hypertension, but it is well under control. A smoker, socially alcoholic patient comes under class 2. When do you call ASA class 3? ASA class 3 means patient having systemic illness not under control. Systemic illness not under control. Okay, systemic illness not under control. Now, guys, remember, systemic illness not under control means what? Just look over here. Uncontrolled diabetes, right? Alcohol dependence, moderate reduction in ejection fraction. These patients will come under ASA class 3. And ASA class 3 means they will be having moderate to severe disease. They will be having moderate to severe systemic illness. When do you call ASA class 4, guys? ASA class 4 means patient is having systemic illness, which is a constant threat to his life. Patient having systemic illness, which is a constant threat to his life. Meaning what? Yani कि patient is posted for some surgery and he's telling you that in the history he's telling you that, doctor, 2 months back I had an MI. Doctor, 2 months back I had a stroke. That is MI or stroke is a systemic illness that poses threat to his life. So life-threatening systemic illness comes under 4. Class 5 means what, guys? Class 5 means moribund patient without surgery. Chances of survival are very less. That patient is moribund patient. Example of moribund patient, example of ASA class 5 is what? Patient having ruptured abdominal aortic aneurysm. Okay, that patient comes under ASA class 5. Okay, next, ASA class 6. When do you call ASA class 6, guys? If the patient is brain dead. Brain dead patient में what surgery you need to do? Brain dead patient में the surgery basically he's the patient for potential organ. You can harvest the organ from the patient. Okay, so that patient comes under ASA class 6, right? So PAC is done, guys. Pre-anesthetic checkup is done. Coming to the second topic of the day, which is called as local anesthetics. Now, guys, in local anesthetics, what we need to remember is first we need to solve this question. Local anesthetic, which is the main mechanism of action, blocks the sodium channel, blocks the potassium channel, chloride or calcium. Remember, guys, local anesthetic will mildly block the potassium, mildly block the chloride, mildly block the calcium channel. But it mainly blocks what, guys? Whenever you give local anesthetic, it mainly blocks the sodium channel. Sodium channel, right? So we are talking about local anesthetics. Remember, we'll just go in brief of what are local anesthetics. Local anesthetics are the drugs which are given in local anesthesia, which are given in spinal anesthesia, which are given in epidural anesthesia, as well as which are given in nerve blocks. Okay, so except of general anesthesia, you use local anesthetics for all these procedures. Now, whenever you give local anesthetic to the patient, how and where, how will it, as we have discussed, the main mechanism is blocking sodium channel. So how it will enter the nerve terminal. Remember, guys, local anesthetic enters the nerve terminal in non-ionized form. Which form? Non-ionized form. Once it enters the nerve in the non-ionized form, it becomes ionized, and then it searches for these channels. What channels? Sodium channels. Sodium channels, which channels, guys? The voltage gated and the inactivated sodium channels. The voltage gated and the inactivated sodium channels, it will go and it will block the sodium channel. Very, very important, guys. What all points we are discussing over here is very, very important. Okay. Once the sodium channel is blocked, depolarization is gone and pain is gone. Okay. That is the mechanism of action of local anesthetics. Now, guys, look over here. Whenever you give local anesthetic, what are the fibers which are first to be blocked and what are the fibers which are last to be blocked? Remember, guys, the fibers which are first to be blocked are usually the autonomic fibers, then the sensory fibers, and then the motor fibers. No controversies, guys. Autonomic, sensory, and motor, right? Now, nerve fiber sensitivity depends on various things, guys. What various things are we talking about? It depends on the myelination, it depends upon the nerve fiber diameter, it depends upon the pH. Okay? So basically, remember, it is the A fibers which are first to be blocked, followed by B, followed by C fibers. A followed by B, followed by C fibers. In the A fibers, what are the nerve fibers which are first to be blocked, guys? It is the gamma fibers, followed by delta, followed by beta, and then alpha fibers. Okay, gamma, delta, beta, and alpha fibers, right? Now, as we are discussing local anesthetics, we'll discuss the classification of local anesthetic. The local anesthetics are classified into two categories. One is called as amino ester, other is called as amino amide. Okay. Now, guys, in amino esters, what we need to remember is the drugs that come under amino ester category are cocaine, procaine, benzocaine, okay, tetracaine, proparacaine. Okay, proparacaine. Remember, how do you remember this? Amino ester. If you look at the spelling of amino ester, how many alphabet of I is there? One I. So all amino ester drugs will have one I in it. All the drugs which comes under amino ester category will have one I. Remember, cocaine was the first used local anesthetic, but remember, cocaine is not at all used nowadays. Why? Why? Because remember, most of the local anesthetic when you give to the patient will cause vasodilatation and cause low blood pressure, whereas cocaine, it will cause vasoconstriction and it will increase the blood pressure. Cocaine is a vasoconstrictive local anesthetic. Vasoconstrictive local anesthetic. Okay. Anyways, we are not using cocaine for local anesthetic or local anesthesia purpose. It is used for some other purposes nowadays. Okay. Now, next, guys. Next is amino amides. When we are talking about amino amides, the second category of local anesthetic, remember amino amides, if you look at the spelling of amino amides, how many alphabets of I are there? Two alphabets. So all the drugs under amino amide category will have two I's. Examples, lignocaine, mepivacaine, bupivacaine, prilocaine, dibucaine. These are the amino amide local anesthetic. The most commonly used local anesthetic worldwide, it is lignocaine. It is what, guys? Lignocaine. The most commonly used local anesthetic in spinal anesthesia is what, guys? Is bupivacaine. The most cardiotoxic local anesthetic is also bupivacaine. Most cardiotoxic. If at all you give bupivacaine intravascular, it will produce cardiotoxicity. It is the most cardiotoxic local anesthetic. Okay. Now, regarding the local anesthetics, we also need to remember which is the longest acting and which is the shortest acting. Remember, guys, lignocaine, other name is xylocaine, or it is also called as lidocaine. Okay. One drug having three names. It doesn't mean that xylocaine में one I है sir, so xylocaine will be amino ester. No, xylocaine is also amino amide. Other name for xylocaine is lignocaine. So anyways, guys, we are discussing about which are the longest and which is the shortest acting local anesthetic. So you need to remember a mnemonic for it. Delhi to Bombay loves PC. Okay? Delhi to Bombay loves PC. D stands for what, guys? Dibucaine is the longest acting local anesthetic. The most potent and the most toxic. Most potent as well as most toxic local anesthetic. Okay? T stands for tetracaine. B stands for bupivacaine. L stands for lignocaine. P stands for procaine. And C stands for chlorprocaine. C stands for chlorprocaine. So longest acting is dibucaine. Shortest acting is what, guys? Shortest acting is chlorprocaine. Okay, shortest is chlorprocaine. Now, remember regarding procaine, you need to, if you can remember, just remember it is the safest local anesthetic used in malignant hyperthermia. Safest local anesthetic used in malignant hyperthermia. Okay. Now, as we were discussing about these local anesthetic, guys, have you heard about proparacaine? Proparacaine is what, guys? Proparacaine is the local anesthetic which is commonly used for ocular anesthesia purpose, guys. Ocular, which topical ocular anesthesia. Topical. If the question is asking you about topical ocular local anesthetic, it is proparacaine. Otherwise, for other kind of block, peribulbar, retrobulbar block, you use lignocaine. Okay. Now coming to what we have discussed, the classification of local anesthetics. We will discuss which local anesthetic produces allergies. Remember, amino esters or amino amide, which will produce allergy, guys? It is always amino esters that produces allergy. All amino esters will produce allergy. Why they produce allergy? Why? Because these amino esters are metabolized to a compound called as PABA. PABA. What is PABA, guys? PABA is nothing but para-amino benzoic acid. Nowadays, the questions are asking which two amino esters are causing this allergic reaction. For that also, you need to remember what, guys? PABA only. If you remember the spelling of PABA, you will get it. And you have to concentrate on P and B. Why? Because the amino ester starting with the alphabet P, that is procaine, causes allergic reaction, and benzocaine causes allergic reaction. Procaine and benzocaine both are causing allergic reaction. Okay, right. Next, guys. A patient develops local anesthetic systemic toxicity after receiving local anesthesia or local anesthetic. Okay, LAST is nothing but local anesthetic systemic toxicity, which is a treatment of choice for managing this patient. Okay, patient develops LAST. Come on. A, B, C, D, what could be given? Okay, basically remember, guys, if the patient develops local anesthetic systemic toxicity, you can give adrenaline, you can also give atropine, you can also give amiodarone, but depending upon what the patient is having. Okay, he has not mentioned the patient develops cardiac arrest or the patient is having arrhythmias. No, he's just saying LAST, local anesthetic systemic toxicity, and he's basically asking which is the treatment of choice. Treatment of choice is you have to give an antidote that basically decreases the absorption of that local anesthetic. What is that antidote, guys? It is 20% of intralipid solution. Okay, adrenaline, atropine can be given, but depending upon what the patient is having. Now, guys, look over here. The chances of local anesthetic toxicity is high when it is given through which route? Come on, guys. We give local anesthetic through many routes. We can give local anesthetic through the tracheal route, through the IV route, through the intercostal route, through the brachial route. Chances of local anesthetic toxicity is high when it is given through the IV route, followed by tracheal, followed by intercostal, followed by brachial plexus. Brachial plexus. The chances of local anesthetic toxicity is high if it is given through the IV route. Now, guys, regarding lignocaine, there have been questions on lignocaine. If you remember 3 alphabets of lignocaine, you can easily solve the MCQs of lignocaine, guys. Lignocaine, remember, guys, Lignocaine starts with the alphabet Lig. With L, what you need to remember, guys? With L, sorry, just a second, guys. Right. With L, what you need to remember is lignocaine is most commonly used local anesthetic worldwide. L say most commonly used local anesthetic worldwide. Next, with I, what we can remember, lignocaine is most commonly used local anesthetic in IVRA, intravenous regional anesthesia. With G, what we need to remember, guys? G, you have to remember garmi. Garmi means hot. Okay, in English, garmi means hot. Hot means what? Lignocaine is the most common local anesthetic to cause malignant hyperthermia. To cause malignant hyperthermia. These three are very important points of lignocaine. Apart from that, what else we need to remember of lignocaine? You have to remember the dose and you have to remember the toxicity of lignocaine. So whenever you give a lignocaine, you have to give it a dose of 4.5 mg per kg body weight. Okay? If you are giving a plain lignocaine. But if you are giving lignocaine with adrenaline, then the dose becomes how much, guys? It is 7 mg per kg body weight. But if you exceed this dose and give to the patient, patient will land up into toxicity, and toxicity produced by lignocaine is commonly manifested in which system in the body? Lignocaine causes toxicity of the central nervous system. Very, very important. Lignocaine produces toxicity of what system? Central nervous system. And bupivacaine produces toxicity of what system, guys? It produces toxicity of cardiovascular system. And what is the first sign of lignocaine toxicity related to CNS? Patient will have perioral numbness. Very, very important. Perioral numbness. Apart from perioral numbness, patient might have tremors, patient might have seizures, but perioral numbness is the first sign. And what is the treatment of choice for any of these toxicities? It is always intralipid 20% of solution. But if at all patient develops bupivacaine-induced arrhythmias, intralipid solution is treatment of choice. But for the arrhythmias caused by bupivacaine, the drug that you give is amiodarone, antiarrhythmic drug, which is called as amiodarone. Okay, that's regarding what, guys? That's regarding the lignocaine. Now coming to regional anesthesia. Guys, is it clear till now? Is it clear till now? Please write in the chat box. Right? We have to rush and all. Is the speed clear? Everything is clear? Right. Okay. Now, guys, starting with this topic called as regional anesthesia. Now, in regional anesthesia, remember, regional anesthesia is divided into two things. One is called as central block, other is called as peripheral neuraxial block. When we are talking about central neuraxial block, what does it have? Central neuraxial block has spinal, epidural, caudal, and saddle. Whereas peripheral nerve block consists of brachial plexus, stellate ganglion block, and ankle block. So we will discuss about these regional anesthesia. Starting with spinal anesthesia. Remember, guys, spinal anesthesia is given for what surgeries? If this is the human body, spinal anesthesia, and this is the umbilicus, guys. Remember, spinal anesthesia is given for any below umbilicus surgery, which is done within how many hours of duration, guys? Which is done within 2 to 3 hours of duration. There you go for spinal anesthesia. What is the site where you give spinal anesthesia? Now, don't tell me directly in the spinal cord. Never we give spinal anesthesia in the spinal cord, but we give spinal anesthesia in the place where spinal cord is present. So remember, guys, which intervertebral space you will insert the needle. For inserting the needle, which intervertebral space? L3 to L5 space. Okay? L3 to L5 space. L4, L5 space indicates a line which is called as Tuffier's line. Tuffier's line. Tuffier's line means that you keep both the hands on the highest point of the iliac crest, thumbs like this. Imaginary line between your thumbs is called as Tuffier's line, that indicates L4, L5 space. And the needle that you use in spinal anesthesia is a dura separating thin bore needle. Dura separating thin bore needle. You cannot use a thick bore needle over here, guys. Why you can't use a thick bore needle? Why? Because if you use a thick bore needle, much damage to the dura can happen and patient will land up into post-dural puncture headache. Now, guys, in spinal anesthesia, there have been questions asking you about what? What are the layers? What is the order of layers pairs in spinal anesthesia? And there have been questions asking you about about certain layers. So the guys, just look over here. As you are passing the needle, what are the layers pierced? Imagine I am passing the spinal needle. First layer is skin. Next is subcutaneous tissue. Next is supraspinous ligament. Next is interspinous ligament. And the toughest ligament to be pierced, look over here. This is the toughest, ligamentum flavum. Next, dura. Once dura is punctured, you will be in the next will be the arachnoid. And once arachnoid is punctured, you will be in the subarachnoid space. There you have to give the drug. There you have to give the drug. Guys, is there any lag in the video? Okay. Right. So remember, order of layers is very, very important. What is the first layer, guys? Skin. After skin, voice is clear, guys, or like no? Okay. So the first layer is skin. Next is subcutaneous tissue. Next is supraspinous ligament. Next is interspinous ligament. Interspinous ligament. Once you pierce the interspinous ligament, what is the next thing that we need to remember? It is the ligamentum flavum. Stop over here. Ligamentum flavum. As your needle pierces ligamentum flavum, you will feel a sudden loss of resistance. Why? Because ligamentum flavum is the toughest ligament, or you can feel the snap. Once your needle pierces ligamentum flavum, there will be dura. Once dura is punctured, next is arachnoid. The last layer to be pierced in spinal anesthesia is arachnoid. Once you puncture the arachnoid, you will be in the subarachnoid space that has CSF. It doesn't mean that subarachnoid is the last, guys. No, it is always arachnoid, the last layer. Now, guys, order of layers to be pierced in spinal anesthesia. For that, you have to remember through a mnemonic, guys. I used to remember this mnemonic as some say spinal instigates lethargy during anesthesia. Lethargy during anesthesia. Some say spinal instigates lethargy during anesthesia. That we have to remember. And the most important two layers that we need to remember is the ligamentum flavum. That is the toughest ligament. And last layer to be pierced is arachnoid. Okay. So that was the order of layers. So guys, remember, once you have punctured the arachnoid, you are in the subarachnoid space. Now you need to give the local anesthetic. Which is the most commonly used local anesthetic in spinal anesthesia, guys? The most commonly used local anesthetic in spinal anesthesia is bupivacaine, which is the most cardiotoxic local anesthetic also. And remember, if at all you want your local anesthetic to act for a longer duration, then what you will do, guys? If you want, sorry, second. Right. If you want your local anesthetic to act for a longer duration, then what you need to do, you need to add something in order to increase the duration. That is called as additive. Now, in the additive drugs, there are many drugs, such as adrenaline you can add opioids and everything. But remember, if you are adding opioids are commonly added, guys. If you are adding opioids, one opioid should be prevented or one opioid should be avoided. What is that opioid? Remifentanil. Why? Because remifentanil contains neurotoxic preservative. So remember, guys, in only spinal anesthesia, you avoid remifentanil. Whereas in other anesthesia procedures, you can give general anesthesia, you can give remifentanil. But for spinal, you avoid it. But a small point of remifentanil is what? It is metabolized by non-specific plasma esterases. Right? Now, whenever you're adding opioids and giving to the patient, there are some side effects that you have to keep in your mind. What side effects, guys? These opioids can produce vomiting as a side effect. Okay? Nausea as a side effect, respiratory depression as a side effect, but that is not the most important. The most common one is what? Pruritus. Pruritus is the most common side effect of opioid that are used in spinal anesthesia. Okay, guys? Next coming to what? Next question. What is the most common intraoperative complication of spinal anesthesia? Now, guys, we have to remember one small point over here. What point we have to remember, guys? Whenever you are giving any procedure, be it spinal, be it epidural, you have to always keep in your mind that complications can happen. Okay? And for that complications, you have to prepare yourself. Okay? So then only you can be a great anesthetist or you can be a great doctor. But we are talking about spinal anesthesia. So I have made my mind that these complications could be seen. So before giving spinal anesthesia, I will prepare a drug tray, which is called as emergency drug tray. We'll come to that later. First, he's asking what is the most common intraoperative complication of spinal anesthesia? Urinary retention? Never. Why? Because it's the most common post-op complication. Okay. Bradycardia? No. It's an intra-op complication, but it is the second intra-op complication that could occur. Headache? Again, it is a post-op complication. Okay. Hypotension. Yes, that's the answer. So remember, the most common complication of spinal anesthesia, intra-op complication, is hypotension. Now, as you give spinal anesthesia, it will block the sensations. Just look over here, guys. As you give spinal anesthesia to the patient, it will block the sensations below the level of umbilicus, and all the blood vessels in the lower extremities will dilate. Yani ki all the blood from the upper body goes to the lower body and settles down. Venous return to the heart decreases, cardiac output decreases, and hypotension occurs. So anyways, guys, the most common intraoperative complication is hypotension. So remember, after giving spinal anesthesia, if you see this thing at the monitor, never you have to panic. But when will you panic, guys? When you are not prepared. When you are not prepared to face this. How will you prepare yourself to face this? You will prepare yourself to face this if you are preparing this emergency drug tray before spinal anesthesia. There is a drug tray called as emergency drug tray, guys, in which we will keep first drug as phenylephrine. Second drug, we keep it as atropine. The third drug that we keep it as pethidine. Next, we keep laryngoscope. In the next column, we keep laryngoscope, ET tube, and adrenaline. Okay. So now, guys, remember, why did I keep this? You have to remember there is no such question that will be asking what is the emergency drug tray and all. Just for your remembrance, I have put this. Why? Because you can remember the drugs as well as the complications. So remember, the first drug that I have kept is phenylephrine. Why? Because the most common complication of spinal anesthesia is what? It is hypotension, which can be easily managed with phenylephrine. If not phenylephrine, ephedrine. But in pregnant ladies, ephedrine is contraindicated. Why? Because it can cause fetal acidosis. So anyways, phenylephrine is a drug of choice. Remember, the second drug that we kept over here is atropine. Why did I kept atropine? Why? Because remember, the first complication is hypotension. The second complication is bradycardia. For bradycardia management, we have kept atropine. The third complication of spinal anesthesia is shivering. Now, guys, why shivering happens? Why? Because as you give spinal anesthesia, as the blood is settling down at the bottom, blood is one of the things that maintains our temperature. If that is settling down at the bottom, then what will happen? Patient will have shivering. For managing the shivering, you have to give pethidine, right? Next complication is high spinal or total spinal. Now, guys, what is meant by high spinal or what is meant by total spinal anesthesia? So everyone look over here. When we are talking about high spinal, what does it mean? Look over here, guys. Imagine I have given spinal anesthesia to the patient, right? And I want my drug to act till this level. Okay? I want my drug to act till this level. I want my drug to act till T10. T10 is what? Umbilicus. Okay? But after giving spinal anesthesia, I test and I found that my drug has gone a bit upward. T8 is blocked or T6 is blocked. T6 is xiphoid sternum. Till xiphoid sternum sensations are blocked. That means what? I wanted to achieve T10, but I have achieved a higher block. That is high spinal anesthesia. Then there is one more anesthesia which is called as total spinal anesthesia. Remember, guys, these two complications will occur. Why? Why? Because if at all after giving spinal anesthesia, you keep the patient in a head down posture, the drug will ascend upward and these complications could occur. Total spinal meaning what? After giving spinal anesthesia, you kept the patient in a head low posture. What happened? The drug has ascended upward into the intracranial segment. Movement of the drug into the intracranial segment will produce respiratory depression, hypotension and all. So that is called as total spinal anesthesia. Right, guys? So anyways, we are discussing about the intraoperative complications of spinal anesthesia. High spinal. As we are discussing high spinal anesthesia, high spinal is characterized by two things together, hypo and brady together. Total means the drug has ascended upward. Okay. But are you worried about high spinal and total spinal? Not at all. Why? Because high spinal hua to hypo and brady and you can give phenylephrine and atropine. If total spinal occurs, patient will be having respiratory depression. So you can give what? You can take the laryngoscope and do the endotracheal intubation. And worst case, what can happen, guys? Cardiac arrest can happen. That can lead to in that case, you can give adrenaline to the patient. Okay, that's regarding what complications, guys? That's regarding the intra-op complications. Coming to the post-op complications. In post-op complications, the most common post-op complication is urinary retention. That is basically due to blockage of sacral fibers. Second complication that could occur commonly is headache, but nowadays it is not at all common, guys. Not at all common. Why? Because we are using a thin bore dura separating needle. But if at all headache occurs after spinal, what is the best management that you should give, guys? Always you go for conservative line of management. Now, what is conservative line of management? Conservative line of management means if the patient after spinal anesthesia complains of headache, you need to understand one thing, guys. Why is the patient having headache? Due to the puncture of the dura, there is loss of CSF. Okay? So conservative line of management means you give the patient bed rest, you give the patient coffee, you give NSAIDs to the patient. That is conservative. But that's not the definitive. The definitive line of management is what? The dura that has been punctured, close that puncture with the help of epidural blood patch. That is the definitive management. The third complication that could occur post-operatively is a sixth cranial nerve palsy. Now, guys, again, sixth cranial nerve palsy is also related to the headache. Why? Because remember, guys, why sixth cranial nerve palsy happens after giving spinal anesthesia? If the CSF is being lost from the dural hole, what will happen? The CSF volume inside the brain decreases, inside the head decreases. Due to that, there will be what? There will be sagging of the brain, right? And it will put pressure on the sixth cranial nerve. That leads to sixth cranial nerve palsy. So the cranial nerve that is commonly damaged in spinal anesthesia is sixth cranial nerve. Now, guys, coming to what? After complications, coming to the contraindications. In which condition spinal is not given? Okay, 4 MCQs, 4 options are given. But in 4 options, one thing is common: appendectomy, 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 appendectomy. For appendectomy, you have to give spinal anesthesia. Appendicectomy or appendectomy is a 2 to 3 hours of procedure. You have to give spinal anesthesia to the patient. Now, if a patient of appendectomy is having hypertension, can you give spinal anesthesia? Come on. Guys, for urinary retention in the post-op period, normally for anesthesia purpose, we are never giving any drug, guys. What we do is we just put a Foley's catheter so that the patient bladder is drained out. Okay, so look over here, guys. Hypertension. If the patient is having hypertension, is spinal contraindicated? No. If at all a patient is hypertensive, having a BP of 170/100, if you give spinal anesthesia, BP will fall and become 120/80. So spinal is not contraindicated. If the patient is having poliomyelitis and posted for appendicectomy, spinal is not contraindicated. If the patient is having INR of less than 1.5, spinal is not contraindicated. Why? Because for contraindication, INR should be how much, guys? INR should be, come on. Remember, contraindications for spinal, there are a few contraindications. INR should be more than 1.5 or platelet count less than 80,000. Remember, hydrocephalus is a contraindication. Why? Because hydrocephalus patient will have a raised intracranial pressure. The moment you puncture the dura, the patient will have, the moment you puncture the arachnoid, the patient will have a gush of CSF. Okay? So remember, contraindications of spinal anesthesia: raised intracranial pressure patient, spinal anesthesia is contraindicated. Apart from that, patient having a platelet count of 80,000, less than 80,000, or INR of more than 1.5, spinal is contraindicated. Apart from that, you also need to remember spinal is also contraindicated in patients who are having HOCM. HOCM is hypertrophic obstructive cardiomyopathy or fixed cardiac output lesions. In fixed cardiac output lesions, spinal anesthesia is contraindicated. Okay, so raised intracranial pressure is a contraindication of spinal anesthesia. Now, guys, identify the procedure set which is being given over here. What is this? Spinal needle epidural set, ascitic fluid aspiration set, or laparoscopic Veris needle set? What is that, guys? Obviously, it is an epidural set which is having an epidural needle, epidural catheter, and other epidural equipments with it, right? So remember, guys, this is what? This is an epidural needle, epidural anesthesia. So as we are talking about epidural anesthesia, we need to talk about the needle. What is the needle that we use in epidural anesthesia? Tuhoy's epidural needle. By looking at the needle, you can tell it's a two-hoist needle. Okay, you will see 1 centimeter of dark and 1 centimeter of light bands on the needle. It is 9 to 10 centimeters long, 18 gauge size two-hoist needle. Okay. Now, guys, remember epidural anesthesia is given for what surgeries? Epidural anesthesia is also given for below umbilicus surgeries, but there are many more indications apart from below umbilicus. Remember, spinal is also given for below umbilicus, but limited duration surgery. Epidural is given for below umbilical surgeries which are done for longer duration, such as total hip replacement or total knee replacement, where the surgeon requires 4 to 6 hours of anesthesia. You can go for epidural anesthesia. Okay. Now, spinal is given only in the lumbar intervertebral space. Unlike spinal, epidural can be given at cervical, thoracic, or lumbar, depending upon for what purpose it is used for. If at all patient is having upper limb radiculopathies, then you can place a cervical epidural. Okay? Or if the patient is having neck pain, you can place a cervical epidural. Whereas if at all you are placing a thoracic epidural, when you place a thoracic epidural, guys, if at all patient is having thoracotomy pain, you can place a thoracic epidural. Or if the patient is having rib fracture, such as 3rd to 8th rib fracture, then you can go for thoracic epidural. Lumbar epidural is used for many purposes, guys. Lumbar epidural is used for like painless labor, and all surgeries below the level of umbilicus for longer duration, you can use a lumbar epidural. Okay, guys, that is regarding the epidural anesthesia. Okay, that's regarding the epidural anesthesia. Now, guys, caudal anesthesia. Caudal anesthesia means what? Caudal anesthesia is usually given in children. Okay? Usually it is given in children who are posted for anorectal surgeries. What surgeries, guys? Anorectal surgeries or perineal surgeries. In caudal anesthesia, caudal is what, guys? It is a you are giving caudal epidural anesthesia. What is the site? It is sacral hiatus. You are inserting the needle at the sacral hiatus. And once you are inserting the needle in caudal anesthesia, the last layer to be pierced, that you have to remember in caudal anesthesia. What is that, guys? The last layer to be pierced in caudal anesthesia is the sacrococcygeal ligament. Sacrococcygeal ligament. Okay? Right. Next, guys, next coming to the peripheral neuraxial block. When we are talking about peripheral neuraxial block, what is the anesthesia? What are the techniques that we need to discuss? We need to discuss about the brachial plexus block. Come on, guys. In peripheral, we have just discussed central neuraxial block, peripheral. In peripheral, brachial plexus can be blocked by 3 routes. One is the interscalene route. Other is what, guys? Other is the supraclavicular approach of brachial plexus, and other is what? Axillary approach of brachial plexus. When you are going for interscalene approach of brachial plexus, guys, remember interscalene approach of brachial plexus is used for what anesthesia? Remember, when you are introducing the needle through the interscalene approach, it will only block the proximal segments. So it is best used for shoulder analgesia. So as it is only blocking the proximal segment, C5, C6, C7, C8 and T1 is not blocked. As C8 and T1 is not blocked, a main nerve leaving C8 and T1 is what, guys? Ulnar nerve is paid over here. Now, guys, as we are talking about ulnar nerve, how to remember this? Remember, MCQ could be asking interscalene approach, what is the nerve that is being blocked? What is the nerve that is being spayed? So remember, I and U are not always together. You have to remember like this. I and U. I stands for interscalene, U stands for ulnar nerve. Are not always together. Okay. Next is supraclavicular approach. With supraclavicular approach, guys, remember what supraclavicular approach, it is regarded as the best approach of brachial plexus. You can block all the segments of brachial plexus, but it comes with complications. As it is near to the pleura, you can easily damage the pleura and the patient might land up into pneumothorax. The most severe complication of supraclavicular approach is what, guys? The patient might have pneumothorax. And the most common complication of supraclavicular approach is phrenic nerve damage. Okay. Coming to the last approach of brachial plexus, which is called as axillary approach. If you are introducing the needle through the axilla, you are basically blocking the distal segments. So this is used for distal arms or distal arm surgery, right? For hand surgery or palm surgery, you can use this. But what is the nerve that is being spared in axillary approach that you have to remember? It is the musculocutaneous nerve. Musculocutaneous nerve that is being spared over here. Now, next is what, guys? After this block, you have to remember something about stellate ganglion block. Now, guys, in stellate ganglion, right? Stellate ganglion, just look over here. This is regarding the stellate ganglion. The last block that has been given is stellate ganglion. Stellate ganglion is used for what? Stellate ganglion is blocked when there is overactivity of the when there is sympathetic overactivity. When there is sympathetic overactivity. So in which condition stellate ganglion is blocked? In Raynaud disease, where the sympathetic overactivity is high and that leads to vasoconstriction of the upper limb, then you can go for stellate ganglion block. Apart from that, any other condition? Catheter induced or drug induced vasospasm. Catheter induced or drug induced vasospasm. Okay. Apart from that, stellate ganglion block. Stellate ganglion can also be blocked if at all the patient is having PTSD, where there is again sympathetic overactivity, where you have to shut down that sympathetic tone. You can go for stellate ganglion block. How will you come to know that stellate ganglion has blocked, guys? The successful sign of stellate ganglion block. Once the stellate ganglion is blocked, you will see what? First sign is what? Ptosis. Sorry. First sign is achievement of Horner's syndrome. First sign is achievement of Horner's syndrome, which is characterized by ptosis, meiosis, and hydrosis. Apart from that, you might see Gutman's sign. Remember, as you are blocking the stellate ganglion, the blood vessels will get dilated and there will be vasodilatation of the nasal mucosa, that is called as Gutman's sign. Apart from that, Muller's sign can also be seen. Muller's sign is nothing but vasodilatation of the tympanic membrane. Okay, right. We give anesthesia in the epidural space only. Okay, next. So guys, that was regarding the regional anesthesia. Now we'll be starting with what? General anesthesia. Now for general anesthesia, again, just listen carefully. General anesthesia is different from other anesthesia. Remember, in regional anesthesia, you are blocking the sensations in the lower part. General anesthesia is usually used for above umbilicus surgeries. Above umbilicus यानी कि cardiac surgery you use general anesthesia. In CNS surgery, you use general anesthesia. Now look over here, guys. In general anesthesia, as we are discussing, we'll first start with the technique called as balance anesthesia. Balance anesthesia means what? In general anesthesia, you don't depend on one drug. You give IV induction agents, you give muscle relaxants, you give inhalational agents in a titrated form so that the patient does not, the drugs do not cause any toxic effect. So that is called as balance anesthesia. All drugs combined and given in a titrated form is called as balance anesthesia. In general anesthesia, my aim should be I should make the patient unconscious and the muscles should be relaxed. For making the patient unconscious, I will use IV induction agents. Okay? And for making muscle relax, I will use muscle relaxant. And for maintaining the patient in an unconscious state, I will use inhalational agents. Inhalational agents. Okay. Now, guys, starting with what? Starting with the IV induction agents. Now, remember in IV induction agent, there are two types. One is called as opioid induction. When do you go for an opioid induction? When the patient's ejection fraction is very low. Why? Because if the patient's ejection fraction is low, you cannot use the conventional IV induction agents. That will cause the patient might land up into cardiac arrest. For any patient who's having a low ejection fraction, you go for opioid induction. If at all patient's ejection fraction is good, and normally in all patients, what you use? Non-opioid induction. In non-opioid induction, you are having the IV induction agents are sodium thiopentone, propofol, etomidate. Okay? And then we are having what? Then we are having ketamine. Why I wrote ketamine over here? Why? Because remember, thiopentone, propofol, etomidate, they are acting through the GABA receptor. Ketamine is a drug that acts through the NMDA receptor. Okay? They are all producing unconsciousness, but they are acting through this receptors. Apart from ketamine in anesthesia, what are the other drugs that will cause, that will basically work through the NMDA receptor? It is the xenon as well as nitrous. Xenon and nitrous also works through the NMDA receptor. Okay. Now, guys, a 25-year-old patient with head injury is brought to the emergency room. He is unconscious, has the signs of raised intracranial pressure. You plan to intubate the patient for airway protection. Which of the following drug is most appropriate in this scenario? Come on, guys. What should you give in this scenario? Patient is having a raised intracranial pressure. He is asking which IV induction should be given. One IV induction should never be given. That I can easily rule out. Ketamine should never be given. Why? Because remember, ketamine, it increases the ICP. Already patient's ICP is high. So you never give ketamine. Now you are left out with propofol and thiopentone. Both can be given. But both will cause decrease in the ICP. But better than propofol is what? It is sodium thiopentone. Sodium thiopentone. So sodium thiopentone can be safely given. Now, guys, as we are discussing sodium thiopentone, we'll discuss some points of sodium thiopentone. Sodium thiopentone is a yellow amorphous powder. It is a yellow amorphous powder and it is regarded as a ultra short acting barbiturate. Ultra short acting barbiturate. Why it is regarded as ultra short acting barbiturate? Why? Because it's having a rapid redistribution. You give sodium thiopentone, after some time it will go into the adipose tissue and the fat and the muscles and it will settle down, right? Due to this, there will be rapid decline in the levels of sodium thiopentone. So remember, guys, it is regarded as ultra short acting barbiturate due to rapid redistribution into the fat, adipose tissue, into the fat and the adipose tissue, due to which you will see a rapid decline. You will see a rapid decline in the level of thiopentone. Okay. Now it has some anti-thyroid properties, and whenever this is available as a powdery form, guys, you have to make it as a solution by adding some water and all. Water means what? It can be prepared in NS and NS everything, except it should never be prepared in Ringer's lactate. Never you have to prepare sodium thiopentone in Ringer's lactate. Why? Because it will form crystals. Okay. Now, guys, as we are discussing sodium thiopentone, we need to discuss the effects of sodium thiopentone on various systems. When we are discussing effects of sodium thiopentone, one line and all MCQs covered. What is that one line? What is that one line? One line is sodium thiopentone is the best friend of CNS and enemy of other systems. And enemy of other systems. When I am talking about systems, what systems, guys? CNS is there, okay? Respiratory is there, cardiovascular is there, muscle is there, analgesia is there. These systems we have to remember. So sodium thiopentone is the best friend of CNS. If you just remember sodium thiopentone, ketamine is opposite of sodium thiopentone. Okay? Propofol, you don't have to remember. Propofol, it just acts like sodium thiopentone only. So remember, guys, sodium thiopentone, it's the best friend of CNS. As I am telling, it is a best friend. It will be used as an IV induction agent of choice in CNS problem. Why? Because sodium thiopentone is decreasing the ICP. So it can be used as an IV induction agent of choice for head injury as well as neurosurgery. Sodium thiopentone can be used safely in patient who's having epilepsy. Pardon my spellings, guys. Okay? Sodium thiopentone can be used safely in narcoanalysis. Narcoanalysis yani ki truth test. Okay? Truth test. It's an investigation of it is a IV induction agent of choice. But sodium thiopentone, as it is the enemy of other system, it will have contraindication for the other systems. It is contraindicated in respiratory problems such as bronchial asthma. Why? Because it's an enemy. It releases histamine, guys. Okay. Apart from that, sodium thiopentone is contraindicated in acute intermittent porphyria. Right. Thank you. Thank you. Right. Now, this is regarding sodium thiopentone. Next, guys. Which IV induction agent is used for TIVA? What is TIVA, guys? TIVA is total intravenous anesthesia. Total intravenous anesthesia means what? General anesthesia given without inhalational agents. That is called as TIVA. General anesthesia given without inhalational agents. So what is the IV induction agent of choice in TIVA? Thiopentone, ketamine, etomidate, or propofol, guys. Only one can be safely given, guys. That is propofol. Why, sir? Remember, TY is total intravenous anesthesia that is commonly used for daycare procedures. For daycare procedures, you want an IV induction agent that usually acts within short period of time and then disappears. What is that, guys? Propofol. Rest all of the IV induction agents require the patient to be in a hospital. So remember, for TY, it is propofol. So as we have discussed, as we have talked about propofol, we'll discuss some things about propofol. Propofol, whenever you see, it's a milky white solution which is made up of egg lecithin, glycerol, and soy or soybean. Okay, egg lecithin, glycerol, soybean, and egg lecithin, and due to this egg lecithin, it usually acts as an emulsifying agent also. Emulsifying agent. And remember, guys, whenever you give propofol to the patient, it will produce severe pain to the patient. It is regarded as the most painful IV induction agents. It doesn't mean that there are no the other IV induction agents are not painful. Etomidate and thiopentone are also painful, but it's the most painful is propofol. And whenever you open propofol, use it within 6 hours. Use within 6 hours. Use within 6 hours, guys. Okay. Now, guys, as we are remembering propofol, dexmedetomidine can also be given for TIVA, guys, but again, IV induction agent of choice for TIVA is propofol. Okay. Dexmedetomidine can be given, midazolam can be given, but again, it is the best one is propofol. Right. Just look over here, guys. Propofol is used as an IV induction agent of choice in what all conditions? For that, guys, you just have to remember this bold letters, daycare surgery. You know what is daycare surgery? Surgery on the same day, discharge on the same day is called as daycare surgery. Now, when we are talking about daycare surgery, all points of propofol will be covered, guys. When a patient is posted for daycare surgery, what anesthesia will I choose for? Will I go for full general anesthesia or TIVA? Normally, it depends upon the procedure, but still, I will go for TIVA, total intravenous anesthesia. Apart from that, next, for daycare surgery patient, will I put an LMA or endotracheal tube? Endotracheal tube is an invasive procedure, will have pain to the patient in the post-op time. So you will go for LMA for daycare procedure. Okay. Next, for daycare procedure, I will choose a drug that is having anti-emetic property as well as anti-pruritic property, anti-emetic as well as anti-pruritic property, right? Apart from that, for daycare surgery procedure, I should choose a drug that is having a safe margin or safety margin for liver disorders, or it should not have any complications such as malignant hyperthermia, right? Or it should not have any complications such as AIP. What is AIP? Acute intermittent porphyria, right? So remember, a patient who's posted for daycare surgery, I'll go for TIVA, I'll go for LMA and all. All these features are covered with propofol. Propofol is the IV induction agent of choice for daycare surgery, IV induction agent of choice for TIVA, for LMA insertion. It's the IV induction that is having anti-emetic property, anti-pruritic, safely given in liver disorders, safely given in malignant hyperthermia. Safely given in liver disorders, malignant hyperthermia is also acute intermittent porphyria. Okay. But remember, propofol should not be given as a long-term infusion in ICUs. What will happen, guys? If you give propofol, patient will land up into propofol infusion syndrome. Again, this is commonly seen in children, guys. Okay. And propofol infusion syndrome, what do you see? You see myopathies. You will see skeletal and cardiac myopathies. Skeletal as well as cardiac myopathies. You will see metabolic acidosis and green color urine. Okay. That's regarding what, guys? That's regarding propofol. Now coming to the next, guys. Which of the following induction agent is contraindicated in schizophrenia? Come on, guys, be fast. In schizophrenia, which is the IV induction agent which is contraindicated? Come on, guys. Very good. The answer is ketamine. Why? Why ketamine? Why? Because remember, schizophrenia is characterized by a thing called as hallucinations. When a patient is already having hallucinations, you avoid a drug that will cause more hallucinations. So what is contraindicated, guys? In schizophrenia, it is ketamine that is contraindicated. As we have started ketamine, we'll discuss some things about ketamine, guys. Ketamine is a complete anesthetic agent. It is basically a phencyclidine derivative and NMDA receptor blocker. It's a phencyclidine derivative as well as NMDA receptor blocker. Once again, guys, I am repeating once again, INI-CET, NEET PG, FMG, all this session covers for in this session, you will see the topics which I am discussing covers all these 3 exams. Okay, so look over here, guys. As we are discussing about ketamine, guys, what is the effect of ketamine on various systems? When we are talking about ketamine, by log, dekho, ketamine is an opposite of thiopentone. Thiopentone was the best friend of CNS and enemy of others. Ketamine is a enemy, worst enemy of CNS. Not only enemy, it is a worst enemy of CNS. Why it's the worst enemy? It increases the intracranial pressure, hence contraindicated in what? Head injury and neurosurgery. Head injury and neurosurgery. Ketamine increases the intraocular pressure, hence contraindicated in glaucoma. Ketamine causes epilepsy, hence it is contraindicated in patients who are suffering with epileptic or seizure disorders. Ketamine causes hallucinations, hence contraindicated in schizophrenia. If at all patient has hallucinations caused by ketamine, it can be easily managed by midazolam, guys. If the patient develops hallucination, normally we don't give, guys. If at all needed, if at all patient is much hallucinating, then you can give midazolam to the patient. Okay, these are the hallucinations, guys. Okay, this is hallucination only. Don't think otherwise. Right, the person is hallucinating, nothing else. Okay, so anyways, I told you ketamine is contraindicated in the CNS problems. Okay, now it is a best friend of other systems. Why am I telling ketamine is a best friend of other systems? What systems? Respiratory. Ketamine can be safely given in bronchial asthma. Why? Because it is having what properties, guys? Bronchodilation. Bronchodilate. It will cause bronchodilation. Okay, it is a next. For cardiovascular system, it is a best friend. So ketamine is a IV induction agent of choice in shock as well as cyanotic heart disease. But in ischemic heart disease, you don't give ketamine. Why? Because it acts on myocardium and it is a cardiodepressant. Okay. Next, ketamine increases the muscle tone. Ketamine increases the muscle tone also. Okay. For asthma, for shock, it is a IV induction agent of choice. Best friend of other systems. Okay. That's regarding what, guys? That's regarding the ketamine. ये कौन सी language है भाई? ठीक है, next. Which of the following intravenous anesthetic agent is associated with highest incidence of nausea and vomiting? Come on, guys. When you give that IV agent, it will cause highest incidence of nausea and vomiting. Which is the IV induction agent which will cause highest incidence? It is always etomidate that causes nausea and vomiting. Which is the IV induction agent that prevents nausea and vomiting? Antiemetic is always propofol. It is always propofol. Okay. Next, guys, coming to etomidate. When we are talking about etomidate is what, guys? Etomidate is the most cardiostable IV induction agent. Most cardiostable IV induction agent, right? But remember, when you give etomidate, when I am telling cardiostable, what does it mean? BP and pulse rate will be maintained after giving etomidate. Once you give propofol, once you give thiopentone, BP will go down. Remember, propofol causes hypotension and bradycardia, thio causes hypotension and tachycardia, but etomidate is a cardiostable. It will neither cause hypo, neither will cause tachycardia. It will maintain the BP as well as pulse rate. But long-term infusion of etomidate can cause adrenal suppression. It will cause adrenal suppression. There is one more drug called as methotrexate. Methotrexate is what, guys? Methotrexate is the IV induction which is commonly given for electroconvulsive therapy, ECTs. Okay, that's regarding the IV induction agents, guys. Okay. Next, an obese patient is posted for axillary abscess surgery as the procedure duration is 15 to 20 minutes. You plan to give sedation and hold the mask. Which agent you would choose in this patient? So there is no risk of airway compromise. Come on, guys. Guys, is my voice clear, please? Why it is not clear? Is my voice clear, guys? Please just answer in the chat box. Voice is clear or not? Yeah. Someone was telling voice is not coming clearly. If there is some problem, just tell me. I will rectify it now only. Okay, clear. So remember, guys, which is the IV induction agent that could be given over here? Remember, the patient is obese. Obese patient, even though in a fasting state, they will be at a higher risk of aspiration. Why? Because their intragastric pressure is high. For these patients, they are at higher risk of aspiration. Okay, that you have to remember. Next, he's posted for 15 to 20 minutes procedure, and you are trying to give sedation and holding the mask, which is the IV induction. If you give propofol to the patient, it will blunt the protective airway reflexes. Fentanyl, again airway reflexes are gone. Etomidate, airway reflexes are gone. With ketamine, airway reflexes are reflexes are preserved. What does it mean? Even though patient is sedated, the patient will be breathing spontaneously. Patient's epiglottis is working. There is no risk of aspiration. So ketamine is the IV induction agent that will preserve the airway reflexes. Okay, guys. Now coming to muscle relaxants. Okay, muscle relaxant. We are in general anesthesia, starting with muscle relaxant. Whenever you give muscle relaxant to the patient, where will it act, guys? Whenever you give muscle relaxant, it will block the it will go to the neuromuscular junction, and it will block the NM or the acetylcholine receptors. Okay, by what mechanism it is blocking, guys? It is blocking by competitive antagonism. The acetylcholine receptors are blocked. And what is the site of action, guys? It is a neuromuscular junction. Now, skeletal muscle relaxants are divided into two categories. One is called as non-depolarizing, other is called as depolarizing muscle relaxant. Coming to non-depolarizing muscle relaxants. When we are talking about non-depolarizing muscle relaxants, they are divided into benzyl isoquinolinoniums and steroidal. Okay? Benzyl isoquinolinoniums examples are atracurium. Okay? Now, guys, just look over here. Before the muscle relaxants came into the market, before the curiums and curoniums came into the market, the first introduced muscle relaxant was D-tubocurare. But this D-tubocurare was having many side effects. Hypotension was seen. That's why we were not using D-tubocurare. Then came the benzyl isoquinolinoniums, in which the first muscle relaxant was atracurium. When atracurium came into the market, this was regarded as a wonder muscle relaxant. Why? Because it was undergoing a magical metabolism, which was called as Hoffman metabolism or Hoffman degradation. Okay? This was regarded as a wonder muscle relaxant. But after some days, what we came to know with atracurium, what was happening, there were some side effects. The side effects what was seen is there was laudanosine formation. Whenever atracurium was given as a long-term infusion, the laudanosine was formed, which was causing seizures. Hence, hence the surgeons told the anesthetist, we won't be using atracurium. Next came the second muscle relaxant, which is called as cisatracurium. Cisatracurium and atracurium both are metabolized by Hoffman degradation. But the difference over here is what? There is less laudanosine seen with cisatracurium. There is more laudanosine seen with atracurium. Yani less side effects are seen with cisatracurium. Okay? Next, after cisatracurium discovery, surgeons told the anesthetist, we want a shortest acting non-depolarizing. Next came the shortest acting non-depolarizing, which was called as mivacurium. Next, after mivacurium is the longest acting non-depolarizing. Which is the longest acting non-depolarizing? It is doxacurium. Next, after the curiums, next discovery was what, guys? Curoniums. In the curoniums, what are the drugs that we need to remember? Next came the second longest acting pancuronium. Next came rocuronium. Next came vecuronium. Okay? Now remember, guys, here the MCQs regarding the shortest and the longest, how you have to remember? I used to remember my short dog has a long tail. My short meaning what? Mivacurium is the shortest acting non-depolarizing, and longest acting non-depolarizing is what, guys? Doxacurium. But again, doxacurium is toxic, hence we are using second longest acting nowadays commonly, that is called as pancuronium. Okay, right? So this MCQ can be easily solved over here. Which muscle relaxant undergoes Hoffman degradation? Remember, it is atracurium. 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 Apart from atracurium, cis atracurium also undergoes Hoffman degradation. So now, guys, muscle relaxant undergoing Hoffman degradation, we already know that is attract as well as cis attract. The side effect is what? Laudonosine. That can cause seizures to the patient. That can cause seizures to the patient. Okay. Next, pancuronium. Regarding pancuronium, what we need to remember, guys, you remember RRR was a movie. RRR, you remember movie RRR? It was a pan-India movie. So for pancuronium also you need to remember RRR. R stands. Remember, whenever anyone asks you about pancuronium, pan meaning RRR. R stands for what? Rate. Pancuronium increases the BP, increases the pulse rate. Hence, it is the muscle relaxant of choice in shock. Muscle relaxant of choice in shock. Okay. Next, R stands for what, guys? Renal. Pancuronium is having maximum renal excretion, hence contraindicated in renal failure. Hence, it is contraindicated in renal failure. Next, pancuronium is the second longest acting muscle relaxant. Hence, sometimes the patient might not recover in time. So third R is recovery. How is the recovery? Delayed recovery with pancuronium. So this is the RRR of pancuronium. Okay. Next is what, guys? Right. So look over here, look over here. Next is what? Vecuronium. When we are asking about when we are talking about vecuronium always remember looks like a heart. Okay? Right? You have to remember heart like this. If you remove the heart, this part, this looks like V. So V for heart, heart for V. Remember why heart you have to remember? Vecuronium is the most cardiostable muscle relaxant. It is the most cardiostable muscle relaxant. Very, very important. Cardiostable muscle relaxant. But it is having what excretion? It is having biliary excretion. Biliary excretion. Hence, it is contraindicated in what? Hence, it is contraindicated if the patient is having any liver problem or obstructive jaundice. Obstructive jaundice also, it is contraindicated. Okay. Next, guys, rocuronium. Now, regarding rocuronium, what we need to remember? Rocuronium is what? Remember rocuronium, when we are discussing rocuronium, RO, okay? Rocuronium starts with the term RO. So RO means rapid onset. Rocuronium is the fastest acting muscle relaxant. Rocuronium is the fastest acting non-depolarizing muscle relaxant. Fastest acting non-depolarizing muscle relaxant. Okay, that's regarding the muscle relaxants. Okay, now guys, in that muscle relaxant, we have to solve this MCQ. Which of the following muscle relaxant is regarded as the shortest acting NDMR? Again, guys, shortest acting NDMR. NDMR is non-depolarizing, ending with curiums or curoniums. The answer is we have already discussed. Yes, yes, yes. I won't be. I'll try to refrain from writing at the bottom. Okay, right. So look over here, guys. Answer is mevaccurium. But if at all the MCQ is asking you the shortest acting muscle relaxant, and he has given an option as Scoline, and he is not mentioned non-depolarizing, then always the answer is Scoline. Shortest acting muscle relaxant is Scoline. Shortest acting depolarizing is also Scoline. Okay, guys. So, anyways, if it is a shortest acting non-depolarizing, it is mevaccurium. Okay, guys. Next. A patient developed a sudden rise in the temperature, rigidity of muscles after receiving a muscle relaxant. A diagnosis of malignant hypothermia was made. Which drug causes this complication? Come on, guys. During anesthesia, patient develops malignant hypothermia. What is the anesthetic drug that can cause malignant hypothermia? Very good, guys. Very good. It is succinylcholine or suxamethonium. As we are discussing suxamethonium, we'll discuss it in brief. What is suxamethonium? Remember, guys, we had discussed the curoniums and the curiums, which were the non-depolarizing. Okay? Remember, guys, in the curiums and curoniums, which is the most, I forgot to tell you, in the curiums and curoniums, benzyl isoquinoline and steroidal, which is the muscle relaxant which will cause allergic reaction, it is always benzyl isoquinoline, which will release histamine. Okay? Right, guys. Right. Next. So anyways, we are talking about depolarizing muscle relaxant. In depolarizing, what is the muscle relaxant that we need to discuss? That is Scoline. Scoline is regarded as the shortest acting muscle relaxant. Why? Because it acts for 3 to 8 minutes, and it is regarded as the fastest acting. Why? Because the onset is 30 to 45 seconds. The onset is how much, guys? 30 to 45 seconds. Now, whenever you give Scoline to the patient, where it is metabolized, whenever you give Scoline to the patient, it is metabolized in the plasma by plasma pseudocholinesterase. By plasma pseudocholinesterase. Okay? But some patients will be having pseudocholinesterase deficiency. In those patients, the Scoline action will be prolonged for a longer period of time, and the patient will land up into a condition called as Scoline apnea, right? And if at all the patient lands up into Scoline apnea, how will it be diagnosed, guys? It will be diagnosed by a test which is called as Diebucane number test. Diebucane number test that will detect basically what is the amount of pseudocholinesterase present in the patient. Okay, that's regarding what? That's regarding the Scoline. So imagine, guys, the patient develops Scoline apnea. And okay, you have given Scoline, the patient should recover in 3 to 8 minutes, but patient had Scoline and it's being 30 minutes and 45 minutes. Patient has still not recovered. How will you manage such patient? Will you give any reversal agent? Remember, Scoline does not require any reversal agent. Reversal agent is only required for non-depolarizing muscle relaxant. What you will do, the best management, if the patient is not breathing after Scoline is, you have to ventilate the patient. The best management of Scoline apnea is what, guys? Providing positive pressure ventilation to the patient. Okay. Now, what is the side effect of Scoline that you see? When you give Scoline to the patient, initially, remember, guys, as you give Scoline, Scoline is a muscle relaxant, but initially it will cause contractions of the muscle, violent contractions of the muscle. It will cause depolarization, and after 10 to 15 seconds, the depolarization is gone, and then the muscles become relaxed. So as due to initial violent contractions of the muscle, the patient will have what, guys? The patient will have the side effect. The most common side effect of Scoline is what? In the post-operative period, when you go to the patient who has received Scoline, the patient complains of muscle soreness, sir. Why muscle soreness? Why? Because he had some fasciculations and all. Okay. Apart from that, patient will also have hyperkalemia. Hyperkalemia. Scoline usually increases the potassium levels by 0.5 to 1 milliequivalent per liter. Okay. It will increase this potassium, right? Now, in normal patient, that's why Scoline is avoided if the patient is already hyperkalemic. If already hyperkalemic patient, if you give Scoline, what will happen, guys? It will worsen the hyperkalemia that can lead to cardiac arrest also. Next, guys. Scoline third side effect is malignant hyperthermia. Regarding malignant hyperthermia, remember, guys, malignant hyperthermia is regarded as the most dreadful complication of Scoline. But my question to you is malignant hyperthermia just seen with Scoline in anesthesia? No. There are many drugs that can cause malignant hyperthermia. Lignocaine can cause malignant hyperthermia in anesthesia. IV induction agent, no IV induction agent. In muscle relaxant, it is Scoline causing malignant hyperthermia. Apart from that, inhalational agents, almost all inhalational agents can cause malignant hyperthermia. Maximum chance of malignant hyperthermia with which inhalational agents? With inhalational agent, halothane. Maximum chance. Okay. Xenon is usually safe in malignant hyperthermia. So remember, guys, malignant hyperthermia is what? It's an autosomal dominant condition seen in autosomal dominant patient. The gene responsible is RYR1 gene. When a patient is having this gene mutation and you give this, and when the patient is autosomal dominant, you give Scoline to the patient, what will happen? It will go towards the abnormal ryanodine receptors and it will stimulate the receptor to produce more calcium. As the calcium is much produced, leading to what, guys? It leads to a sustained muscle contraction that usually starts in the masseter. The muscle spasm usually starts in the masseter muscle. So how will you diagnose malignant hyperthermia, guys? For diagnosing malignant hyperthermia, there is a test called as halothane caffeine test. Halothane caffeine test. And what is the treatment of choice or drug of choice for malignant hyperthermia? The treatment or drug of choice for malignant hyperthermia is, again, guys, in the pharma also, you might have seen what is the drug of choice for malignant hyperthermia? It is dantrolene sodium. Dantrolene sodium. Okay, that's regarding what, guys? That's regarding the malignant hyperthermia, right? Next, patient was planned for surgery under general anesthesia. In the induction phase, we had given rocuronium, but the anesthetist failed to intubate the patient. Which could be the best reversal agent used over here? So basically, he's talking about the reversal agents over here. Remember, guys, for reversing the patient from anesthesia effect, you need to give a reversal agent that acts against the muscle relaxant, that is cholinesterase inhibitors. Okay? But for cholinesterase inhibitors are given for almost all muscle relaxant, but he's asking rocuronium. For rocuronium, it requires a modified gamma cyclodextrin, which is Sugammadex. Sugammadex is a reversal agent which is commonly given for rocuronium as well as vecuronium. Okay, so we are talking about what, guys? We are talking about the reversal agents. Now, when we are talking about reversal agents, guys, remember reversal agents. What are the reversal agents? Neostigmine, which is a cholinesterase inhibitor, which is the most commonly used reversal agent. But if you use neostigmine, what will happen, guys? If you give plain neostigmine for reversal, patient will have bradycardia. So in order to counteract this bradycardia, we give neostigmine plus either atropine or either glycopyrrolate that will basically counteract that bradycardia. Apart from that, pyridostigmine, L-cysteine can be given, edrophonium can be given. Physostigmine is not used, guys. Physostigmine is never used as a reversal agent. Why? Because it crosses the blood-brain barrier. It crosses blood-brain barrier. Okay, I told you Sugammadex is used for what? Sugammadex is used for rocuronium as well as V stands for vecuronium. Rock and vecuronium. Is it clear, guys? And how will you come to know that your patient has adequately reversed? There are two things, guys. One is a clinical test, other is the best test. So remember, guys, bedside sign, yani ke you are near the patient. What is the best bedside sign that indicates that the patient has reversed from the effect of muscle relaxant? That is, you tell the patient to lift his head. If he is having a sustained head lift, or if he is lifting his head for more than 5 seconds, that it is a best bedside sign that indicates patient has been reversed. Overall, best clinical sign is what, guys? A train of 4 ratio more than 0.9. We'll discuss what is train of 4 ratio and all later. Okay, train of 4 ratio more than 0.9. Now coming to what, guys? Inhalational agents. Inhalational agents. So guys, inhalational agents are used for what? Inhalational agents are used for two things. What two things? They are used for maintenance as well as induction. Inhalational agents are used for, remember, 99% they are used for maintenance, yani ki maintain the patient in the unconscious state. In 1%, yani ki in children, in children you use inhalational agent for induction purpose. Why? Because children won't allow you to put an IV cannula. IV cannula, if it is not possible, IV induction is not possible. Okay, and the induction agent, inhalational induction that is given is sevoflurane, sweet odor sevoflurane. Okay, now guys, we'll solve this MCQ. Which is the most potent inhalational agent? Nitrous methoxy, sevo, or des? Which is the most potent? Remember, guys, who determines which is more potent, which is less potent? I am not the one who determines which is less or which is most potent. Just look over here. Who's the which is the thing? MAC determines the potency of inhalational agents. MAC is what, guys? MAC is minimal alveolar concentration. That determines the potency of inhalational agent. But always remember, MAC is inversely proportional. That means what? Inversely proportional to the potency. Meaning what? High MAC is equals to low potent, and low MAC is equals to highly potent. Any drug that is having a low MAC value, will be highly potent. Highly potent. Okay. Now, regarding the potency, what you need to remember, there is a mnemonic, guys. Most potent to least potent. Just look over here. The mnemonic is HISD. Just add before H, just add this alphabet M. Even though this inhalational agent is not used, but you have to remember. This is the order of potency. Most potent to least potent. If you go in this order, you will get most potent to least potent. If you read from this order, you will get fastest to slowest onset. So remember, guys, most potent is what? Methoxyflurane. Our MCQ is solved. Which is the most potent, guys? Methoxyflurane. Why? Because it's having a low MAC value of 0.16. Next is what? Halothane. Halothane having a MAC value of 0.75 second. Next is what? Isoflurane. 1.16 is the MAC value of isoflurane. Okay. Next is what? Sevoflurane. MAC value is 2. Next is what? Desflurane. MAC value is 6. Next is what? Xenon. MAC value of 70. Okay. So that is the least potent. That is the least potent. That is regarding the most potent to least potent. But if you go in this order, if you start with X, D, S, I, H, M, in this order, you will get what? You will get the fastest to slowest onset. But who determines what is fastest and what is slowest? MAC was determining potency. Blood gas coefficient determines the speed of onset and recovery. Any inhalational agent that is having a high blood gas coefficient, it will be slow onset as well as slow recovery. And any inhalational agent that is having a low blood gas coefficient, it will be fast onset and fast recovery. But again, guys, this is also inversely proportional. Inversely meaning what? Inversely meaning what? High blood gas, slow onset, and low blood gas, fast onset. Okay. So look over here, guys. Look over here. Fastest to slowest. I told you if you want to remember fastest to slowest, you have to remember the MAC. Okay. MAC was MHISD-X. If you start with X, X is xenon. Xenon is the fastest acting inhalational agent. D is what, guys? Desflurane. Desflurane. S is what? Sevoflurane. I is isoflurane. And H is halothane. The slowest is halothane. The fastest is xenon. Okay? Xenon is regarded as the ideal inhalational agent with no systemic side effects. With no systemic side effects. Okay? Whereas desflurane causes maximum airway irritation. Okay? Someone was asking, what about nitrous, sir? Remember, in the MAC, nitrous is having the highest MAC of 105, is the least potent. Nitrous nowadays is not used as a main inhalational agent. It is used as a carrier gas. That's why I have not written nitrous over here. Okay. So, anyways, guys, this is regarding what? This is regarding the inhalational agents. Now, we'll solve this MCQ. A patient presents with nausea, vomiting, tender hepatomegaly with a raised bilirubin diagnosed to have an acute liver injury 2 weeks after axillary abscess surgery. Which could be the inhalational agent responsible for it? Come on, guys. What's the answer for it? What's the answer for it? Come on, be fast. A, B, C, D. Come on. Right. The answer is C, halothane. Why halothane, sir? Remember, patient is having nausea, vomiting, hepatomegaly with raised bilirubin means patient is having an acute liver injury. He has not given. Patient is having sepsis, which has caused acute liver injury. Patient is alcoholic. Nothing is given over here. Okay. He underwent surgery and inhalational agent was used. Any inhalational agent that causes damage to the liver is what? It is halothane. Repeated use of halothane can cause immune-mediated hepatitis, that is called as halothane-induced hepatitis. That is called as halothane-induced hepatitis. That is an immune-mediated hepatitis. Okay, that's regarding halothane. Now, if anyone asks you about halothane, only 4 H should be your answer. 4 H's of halothane. What 4 H's of halothane, guys? The first H is what? Halothane causes hyperthermia. What hyperthermia are we talking about, sir? Malignant hyperthermia. Almost all inhalation agent, but maximum incidences with halothane. Next is what, guys? Heart disease, halothane is contraindicated. Why? Because halothane, if you give, normally when you give halothane to the patient, what will it do? It will cause hypotension, it will cause bradycardia, and it will also cause arrhythmias. It will also cause arrhythmias. Okay. Next stretch of halothane is what, guys? Next stretch of halothane is hyperthermia, heart disease. Next is hepatitis. Halothane-induced hepatitis. Next H is what? Halothane has 2 maximum. What 2 maximum? One is maximum bronchodilation. Maximum bronchodilation. And next is what? Maximum muscle relaxation. Maximum muscle relaxation. Okay. So that's regarding the 4 H's of halothane. 4 H's of halothane. Okay. Next. Now look over here, guys. Which inhalational agent is commonly used for cardiac surgery? Come on, guys. For cardiac surgery, which is commonly used inhalational agent? For cardiac surgery, the best inhalational agent would be, the answer should be desflurane. Okay, but as it comes with a special vaporizer which is very costly, we don't use this. The most commonly used is isoflurane. Isoflurane. Okay, isoflurane is the most common inhalational agent used in what surgery, guys? Used in cardiac surgery. Even though we know it is having a side effect. What side effect, guys? Although it is just proved in animal studies, what side effect are we talking about? Isoflurane can cause coronary steal phenomena. Coronary steal phenomena. What is coronary steal phenomena? Coronary steal phenomena is nothing but when you give isoflurane to a patient who's suffering with coronary heart disease, it will steal the blood from the bad coronary and give it to the good coronary. So basically, it is reverse Robin Hood. Reverse Robin Hood phenomena. Coronary steal phenomena can be seen with isoflurane. It can be safely given in renal patients also. Next is sevoflurane, guys. Sevoflurane. Sevoflurane has a special place in my heart, special place in children's heart also. Why? Because sevoflurane is a sweet odor inhalational agent. Why it is having a special place in my heart? Why? Because sevoflurane I can use for induction purpose. I can use for maintenance purpose. Okay? Sevoflurane I can use for many purposes, right? Why for children? Remember why? Because it's having a pleasant odor. So sevoflurane is regarded as an inhalational agent of choice in children due to its sweet odor. Sevoflurane is regarded as an inhalational agent of choice in bronchial asthma. Now, guys, you might be confused. Halothane, sir, you told 4 heads of halothane. Halothane is causing maximum bronchodilation. It should be used. But remember, till 2 years back, halothane was used. But nowadays, studies have confirmed that halothane is causing some airway resistance. So better than halothane is what, guys? It is sevoflurane in bronchial asthma. Okay. Next is what, guys? Sevoflurane is a inhalational agent of choice for daycare surgery. Now, daycare surgery, you want an inhalational agent or you want an IV induction agent. Remember, if IV induction agent of choice for daycare surgery was propofol. Why? Because it was a short duration. Inhalational agent would be sevoflurane. Okay? Why? Because it's having a low blood gas coefficient. Previously, it was desflurane, but desflurane was causing airway irritation. That's why we are using sevoflurane. Next, for neurosurgery also, it is sevoflurane. Initially, it was iso, but now we are using sevoflurane for neurosurgery. Okay, guys? Next, nitrous oxide. Okay. Nitrous oxide. Come on, guys. Nitrous oxide, what you need to remember? Are we using nitrous oxide as a main gas? Never. Nitrous oxide is always used as what gas? It is used as a carrier gas. What is meant by carrier gas? Whenever you use some other inhalational agent, with that you use nitrous oxide. Okay? Nitrous oxide, what is the cylinder color? Nitrous, always remember Neela. Neela. Neela means what, guys? Neela is nothing but blue. Neela yani ke blue. So nitrous is stored in what color cylinders? Blue color cylinder. It's a good analgesic, but it is avoided in patients who are having what? It is avoided in patients who are undergoing any closed loop surgery or cardiac surgery or pneumothorax. Why? Because nitrous has the habit of accumulating in the air containing cavities. In pneumothorax also nitrous is contraindicated. In cardiac surgeries, never give nitrous. Why? Because it increases the pulmonary vascular resistance. Okay. But with nitrous, what you need to remember is, nitrous does two things. What two things would be seen with nitrous? It causes diffusion hypoxia and it will cause second gas effect. What is diffusion hypoxia, guys? It is commonly seen at the end of surgery. At the end of surgery, as you are cutting down the gases, nitrous, oxygen, what will happen? Nitrous as imagine, guys, this is the alveoli. Nitrous will basically occupy the alveoli. But at the end of surgery, as you are cutting down the nitrous, what will it do? Imagine this yellow color molecule is oxygen. So what will it do at the end of surgery as you're cutting the nitrous? Nitrous will take itself out with oxygen. Yani it is displacing oxygen outside, leading to what? Hypoxia. Hence, what we do, guys, at the end of surgery to prevent diffusion hypoxia, we give 100% of oxygen. We give 100% of oxygen. This can be easily prevented. Next, second gas effect can also be seen with nitrous. Yani ke whenever you're using nitrous and some other inhalational agent with it, always it is used with other inhalational agent only. What will it do? Nitrous will increase the concentration of other inhalational agent. That is called as second gas effect. Okay. Pulmonary vascular resistance, guys. PVC pulmonary vascular resistance. Okay. That's regarding nitrous. Now coming to the summary of all summary of the general anesthesia, guys. This is a very, very important thing, guys. On my Instagram page also, you will find this. Okay. Now just look over here. Summary of general anesthesia. Patient suffering with heart disease, asthma, shock, daycare surgery, neurosurgery. Remember, any patient who's posted for general anesthesia, you will first give IV induction agent, then muscle relaxant, then you give inhalational agent. In this order, you have to remember, then only the mnemonic, then only everything will act. Okay? So always remember, guys, heart disease patient. Heart disease patient, what is the IV induction? What is the muscle relaxant? What is the inhalational agent? Heart disease patient, you have to remember, heart disease patient enjoys very deep inhalation. Okay, heart disease patient enjoys very deep inhalation. We'll come to that. Why am I talking it? Okay, why? Because remember, what is the IV induction agent of choice for heart disease patient? E stands for what? Enjoys. E stands for heart disease patient etomidate. Why etomidate? Why? Because it's the most cardiostable muscle relaxant. Next, which is the most cardiostable IV induction agent is etomidate. Next, V stands for what, guys? Vecuronium, cardiostable muscle relaxant. So heart disease patient enjoys very deep inhalation. D stands for desflurane, which is the best for heart disease. And I stands for isoflurane. I stands for what, guys? Isoflurane, which is most commonly used in heart disease. Next, asthma. For asthma, what we need to remember? Asthmatic kids always seek help. What does it mean? Okay, asthmatic kids. Yani what is the IV induction agent? Again, just concentrate on K. Ketamine is the IV induction agent that could be given in bronchial asthma. Why? Because it's having a bronchodilator property. Muscle relaxant, any muscle relaxant could be safely given in asthma, but try to avoid benzyl isoquinolinoniums. Why? Because they release histamine. Next, seek help. Which is the best inhalational agent for asthma? Sevoflurane. Second best inhalational agent is what, guys? Second best inhalational agent is halothane. Okay. Next, shock. If the patient is in shock यानी कि patient's BP is 70/40. What is the IV induction agent, muscle relaxant, and inhalational agent? Come on, guys. For shock, what we need to remember? Shock kills the patient directly and indirectly. Okay. So what is the IV induction agent? Ketamine is the IV induction agent of choice in shock. Okay. P is pancuronium, RRR of pancuronium. Okay. That's a muscle relaxant of choice in shock. Directly and indirectly. D stands for what? Desflurane. Again, the best. But most commonly we choose what? Isoflurane in shock. Okay. Next is what? Daycare surgery. For daycare surgery, what do you need to remember, guys? Daycare surgery, patient may sleep. Daycare surgery, patients may sleep. Okay. Daycare surgery, what is the IV induction agent, guys? It is propofol. Propofol, short duration of action. Muscle relaxant of choice for daycare surgery, mebarcurium. Someone was asking me muscle relaxant of choice for daycare. I hope the query is solved. Mebarcurium. Next, sleep. S stands for what, guys? For daycare surgery, it is sevoflurane. Previously, it was desflurane. Now it is sevoflurane. Next is neurosurgery. For neurosurgery, which is the IV induction agent, guys? Thiopentone. Okay. Remember neurosurgery. You have to remember neurosurgeons treat all safely. Okay. T stands for thiopentone. A stands for any muscle relaxant could be given, and S stands for sevoflurane. Second best for neurosurgery is what? Isoflurane. Second best for neurosurgery is isoflurane. Is this thing clear, guys? Come on, is the summary clear to everyone? It took some time and effort. Is it clear? Right. Whenever you're feeling down, guys, always ask yourself how bad you want that PG seat, whether you want radio, whether you want derma, whenever you're preparing for NEET PG, INI-CET or FMG, anytime whenever you feel low, always think about this. How bad you want it. Either you want it or you don't want it, but you can't be in the middle. Middle means what? I will study for some time, I will not study. You have to study for it, okay? So anyways, guys, we'll start with this rapid sequence induction. Come on. So rapid sequence induction. Rapid sequence induction means what, guys? RSI. What does rapid sequence induction means? It is nothing but general anesthesia given to patients who are at risk of aspiration. GA, given to patients at risk of aspiration. Who are the patients who are at risk of aspiration? The patients who are obese, pregnant ladies, okay, emergency surgeries. These are the patients who are at risk of aspiration. In those patients, you give general anesthesia. That is called as rapid sequence induction. Now, what do we do in rapid sequence induction? It is same like general anesthesia. You pre-oxygenate, then give induction agent, then you intubate and all. Here, what are the steps that we change over here? In rapid sequence induction, in general anesthesia, we pre-oxygenate with bag mask. In rapid sequence induction, we pre-oxygenate with normal mask. Bag mask is avoided. BMV is nothing but bag mask is avoided. Why? Why? Because if you give bag mask ventilation, you are forcefully pushing the air inside the esophagus. If the patient is full stomach, he will aspirate. Okay, bag mask ventilation is also avoided if the patient is suffering with congenital diaphragmatic hernia. So anyways, we have pre-oxygenated. After pre-oxygenation, next immediate step is what? You have to give IV induction agent. As you give IV induction agent, patient is unconscious. As the patient is unconscious, his epiglottis is unconscious. You need to tell your assistant to put pressure on the cricoid cartilage and apply some pressure. Then you give some muscle relaxant. Okay? First you give IV induction agent, then you put cricoid pressure and then give muscle relaxant. So remember, what is the pressure whether it is applied called as? That is called as cricoid pressure. Once you apply the cricoid pressure, what will be closed, guys? This esophagus will be closed and the patient won't be aspirating. That is called as what? Selleck's maneuver. That is called as Selleck's maneuver. Now the next question that could be asked is what? When are you removing the Selleck's maneuver? You will remove this cricoid pressure after intubation is done and after inflating the cuff. Okay? The pressure is removed after intubation is done and after inflating the cuff. That is important, guys. After inflating the cuff. Okay? Once you are in the trachea, when will you remove? After cuff is inflated so that it encircles the whole tracheal lumen and aspiration risk is avoided. That's regarding the RSI. Now, guys, coming to this anesthesia equipments and IV cannula. When we are discussing about anesthesia equipments and IV cannula, guys, what are the IV cannulas that we need to discuss? That is the first line that we need to remember, guys. This is the first line, the first lifeline that is available in the hospital. You need to give any drugs, IV cannula. Any fluid, IV cannula. There are different sizes of IV cannula. Most commonly used in pediatrics is 24 gauge, that is yellow color. But guys, for remembering IV cannula colors, there have been questions on cannula colors. There have been questions on cannula gauze and there have been questions on the flow. Guys, remember this one thing, you can easily remember the IV cannulas. Okay? Remember the mnemonic is what? Oh great God, please bless your people for IV cannulas. Okay? O is what, guys? Orange in color. O is orange color. Okay? Great means it is gray. Great means gray in color. God means green in color. Okay? Please means pink in color. Next, blue in color. Next, yellow. Next, please bless your people, yani ke it is purple in color. Okay? And gauze size is what? Time I have already mentioned, it could be 3 hours, total 3 hours or 3.5 hours can occur. Okay? 3 hours, 15 minutes can occur. Okay? For the session to finish. Now, how much time left? I can't tell. 1.5 hour could be there. Okay? Just look over here, guys. Gauze size is what, guys? Always the cannula starts from what gauze? 14 gauze. Next, 16. Next, 18. Okay? Green corresponds to 18. Next, 20. Next, 22. Next, 24 gauze. Next, 26 gauze. The smallest is purple, but again, not used commonly. In pediatric cases, commonly used is yellow color. Whereas In hospitals for surgeries, we are using commonly for surgeries, we are using the green and pink color. Whereas for blood transfusions, we are using orange and gray color. For shock and blood transfusions, we are using orange and gray color. So now guys, there have been questions about the flow of IV cannula. Now, if you want to remember the flow, you need to go from the last to top. Okay, bottom to top. So remember, with purple color cannula, you can give fluid for 10 ml per hour. Okay, with yellow color cannula, 24 gauze, you can give 20 ml per hour. Just add more 10. Then with 22 gauze, you can give 30 ml per hour. With 20 gauze IV cannula, you can give 50 ml per hour. With 18 gauze, you can give up to 100 ml per hour. With 16 gauze, you can give 200 ml per hour. Whereas with 14 gauze, you can give 270 ml per hour. Okay, these are the approximate values, guys. 1 or 2 ml doesn't matter over here. Okay, so these are the things that you need to remember regarding the IV cannula. Now, next question. What's the color of Entonox cylinder? Come on, guys, be fast. Tell me what's the color of Entonox cylinder. But you must be wondering, we were just discussing IV cannulas. What is Entonox cylinder? Just look over here, guys. Now we'll discuss about the anesthesia machine. If you want to answer the Entonox cylinder, okay, apart from that, there is one more question. What is the color of oxygen pipeline? These two questions we'll solve once we complete the anesthesia machine some parts. Okay, so guys, remember this picture on your screen is called as anesthesia machine, or it is also called as a Boyle's machine, which was introduced in 1917 by Edmund Gaskin Boyle in order to reduce the pressure of the gas. Now guys, this machine is divided into three systems. What three systems? The high pressure, intermediate pressure, and low pressure. In high pressure system, you will have what? You will have cylinders, you will have yoke valve assembly, you will have pressure gauzes and pressure reducing valve. Pressure gauze and pressure reducing valve. Whereas an intermediate pressure system, flow control valve is there, oxygen and nitrous proportionating devices are there. Okay? Oxygen flush is there. And in low pressure system, you are having rotameter, vaporizer, and common gas outlet. Now, guys, we have to remember the parts of the machine. The first part of the machine is cylinder. What is the material the cylinder is made up of? Cylinder is made up of molybdenum, and this molybdenum cylinder is non-MRI compatible. Never take the cylinder in the MRI room. If you want to use an MRI compatible cylinder, MRI compatible cylinders are either made up of titanium or either made up of aluminium. There are different sizes of cylinders available, small to the large. The smallest size cylinder is A, the largest is J, but the most commonly used cylinder is what, guys? Size E cylinders. And all these cylinders are given color coding so that you can just, by looking at the cylinder color, you can tell what gas is present in the cylinder. Okay, so now color coding of the cylinder. Now color will be basically divided into body and shoulder. So remember, oxygen, what is the color coding? Oxygen, remember guys, oxygen is like a bodyguard to the patient. When a patient is in anesthesia, oxygen is the thing that acts as a bodyguard. Okay? When a patient is alive and if he wants to keep a bodyguard, what is the color dress that he gives to bodyguard? Bodyguard will be wearing black body and white shoulder. So oxygen cylinder is a bodyguard. So you will be having black body, white shoulder. Black body, white shoulder. Okay? Next, air. Air is completely opposite of oxygen cylinder. That is, it is white body, black shoulder. Next, nitrous. Nitrous बोले तो सिर्फ नीला ही आना. नीला means nitrous is blue cylinder. Next, Entonox. When we are talking about Entonox, Entonox is what? It is a mixture of 50% nitrous and 50% oxygen. Entonox is not used for anesthesia purpose. It is used only for analgesia purpose. Okay. So Entonox means what? Blue body and it is white shoulders. Blue body and okay. I can't write white with white ink. Okay. White shoulders. Carbon dioxide. Carbon dioxide is it's a gray color cylinder. Okay. Now guys, two things you have to remember this. Okay, one is the cylinder colors. Okay, apart from that, helium is having brown and all. You have to remember these are the mains. Now, if you want to remember the pipeline, remember apart from cylinders, we'll be having a central supply of gases which are usually coming through the pipe. Okay, oxygen, nitrous, all are all supplied by pipeline. Okay, these pipelines are also given color coding. The color coding of pipeline is simple. Just remember the shoulder colors of the cylinders. Okay. Oxygen, what is the shoulder color? White. So pipeline of oxygen is what? White pipeline. Air, what is the shoulder color, guys? What is the shoulder color of air cylinder? Black. So what is the pipeline color of air? It is black. Whereas nitrous, complete blue. So the pipe is also blue. Vacuum, there is vacuum cylinder. Remember, guys, vacuum, whenever you're writing V of vacuum, add a stroke, it will become Y. So it is yellow color. Vacuum is what color, guys? Yellow color. So this is regarding the cylinder colors and cylinder pipelines. So two MCQs can be easily solved over here. The Entonox cylinder is what, guys? It is blue body and white shoulders. Okay. And what is the color of oxygen pipeline? Come on, guys. What's the color of oxygen pipeline? It is, come on, oxygen is black body, white shoulders. So pipeline color will be the shoulder. Shoulder is what? White. Okay. Answer is this. Okay. Next. Next, guys, what is the pin index system of Entonox? Come on, guys, what is the pin index system of Entonox? As I already told you, Entonox is not at all an anesthesia related gas. It is always what gas, guys? It is used as an analgesia. Okay, so Entonox can be used for painless labor and all. What is the pin index system? First of all, what is meant by pin index system? You need to answer that. Okay, most of you have given the right answer. The Entonox pin index system is 7, but how? We'll come to know it now. Okay, now look over here, guys. Pin index system is what? In the yoke valve assembly, remember cylinders are attached to the machine with the help of an assembly called as yoke valve assembly. In the yoke valve assembly, there is a system that prevents wrong attachment of the cylinder to the machine, where the pins are present on the machine and holes are present on the cylinder. Okay. Now, there are different gases are given different pin index system. Air is given a pin index system of 1,5. Oxygen is given a pin index system of 2,5. Nitrous is given a pin index system of 3,5. Concentrate on these three first. Okay, air, oxygen, and nitrous. You have to concentrate. Now, guys, how to remember this? Remember, air pin index system is 1,5. One thing is common in these three gases. The second pin index system for these three gases is what, guys? 5. We just have to remember first pin index. So air. When we are talking about air, air starts with first alphabet. Yani air starts with A alphabet. And A is the first alphabet. So it will be 1, and second pin index for most of the gases it is 5. Okay. Oxygen. When you are writing oxygen, you should write O2. Yani it will be O2 means 2. This 2 will come over here, 2, 5. Nitrous. Nitrous means 2 molecule of nitrogen and 1 molecule of oxygen. How many molecules? 3. So it will be 3, 5. 3, 5 for nitrous. Okay. Entonox. Remember for Entonox, what is the pin index system, guys? Entonox, how many alphabets are there in Entonox? 7. The pin index system of Entonox is 7. Okay. What is the pin index system of carbon dioxide? It is carbon dioxide. I'm writing it on the top, guys. It is 1,6 or 2,6. 1,6 or 2,6. That's regarding what? That's regarding the pin index system. Now, guys, there is one more system that prevents the wrong attachment of the pipelines. What is that system called as? Diameter index safety system. Just look over here, guys. Diameter index safety system prevents the wrong attachment of the pipeline. Now, in this video, I have taken the white pipe. What is that white pipe, guys? Come on, answer in the chat box. What is the white pipe that I have used? It is the oxygen pipe. Okay. So anyways, so I will take this white pipe and I'll try to put this white pipe into the vacuum port. It's not going. But when I take this white pipe and put it into the oxygen port, it easily fits. So what is the system that prevents the wrong attachment of the pipeline? That is called as diameter index safety system. Okay. Next is what, guys? Vaporizer. When we are talking about vaporizer, what is vaporizer means? Vaporizer is a device that stores the liquid inhalational agent. What is the material the vaporizer is made up of? Vaporizer is made up of copper. Vaporizer is made up of copper material. Okay. Now, almost all inhalational agents are stored in one vaporizer except desflurane that requires a special vaporizer as it is having a low boiling point. Okay. Vaporizer colors you have to remember, guys. What is the colors of vaporizer? Halothane, what is the color, guys? Halothane. Halothane, hellfire, looks like red. So halothane is what color vaporizer? Red color vaporizer. Isoflurane is purple color. Whereas sevoflurane, sevo is sweet. Sweet यानी कि sevo सेवैया, सेवैया is sweet. ठीक है? And it is in yellow color. Sevo, you have to remember सेवैया, that is yellow color. Sevo is yellow color vaporizer. Desflurane, desflurane, whenever you remember vaporizer color is desflurane is desi. Desflurane means what? Des means desi. Desi jersey color is what, guys? Blue color. Blue color. Okay. So that's regarding the vaporizer colors. Okay. Next, guys. Coming to the breathing circuit. Guys, before proceeding to the breathing circuit, is it clear or I'm just going in just express? Is it clear? Please, guys, your feedback is very, very important. After the session also, the feedback is important. You can write in the comments. You can write, okay. Right. Next. Which breathing circuit is regarded as a circuit of choice for controlled ventilation in pediatrics? Thank you. Okay. Circuit of choice for pediatrics. Now, guys, remember ABCD. What's the answer over here? In pediatrics, remember there are some breathing circuits, open breathing circuits and closed breathing circuits, and open breathing circuits are there, semi-open breathing circuits are there, and closed breathing circuits. We are using the semi-open or semi-closed breathing circuits. Now look over here, guys. Which is the circuit of choice for pediatric ventilation? Okay, he is asking for controlled pediatric ventilation. For pediatric, answer should be always, remember, guys, these are Mapleson A till F. The circuit of choice for pediatric is always Mapleson F, that is Jackson-Rees modification. Now, if at all the question was not given pediatric, if he asked you circuit of choice for controlled ventilation, always remember. So do we have to study anything extra for anesthesia for PG? Guys, I have incorporated most of the things over here. Okay, if you want to do previous years, you can do, but again, previous years is also covered in this rapid review. Okay, so look over here, guys. If at all the question was circuit of choice for controlled ventilation and pediatric was not there, always remember this, guys. SACD. SACD you have to remember for breathing circuits. SA meaning what? For spontaneous ventilation, the circuit of choice is A. For controlled ventilation, the circuit of choice is D. Okay? For pediatrics, whether it is spontaneous, whether it is controlled, it is always Mapleson F circuit. Now we'll discuss something about the breathing circuits. Breathing circuits. Okay? Breathing circuits means Mapleson A is there, Mapleson B is there, C is there, D is there, E and F is there. Okay? Now we have to remember the Mapleson A circuit. Mapleson A circuit is also regarded as Maggle circuit. It is also regarded as Maggle circuit. This is the circuit of choice for spontaneous ventilation. Okay? And the fresh gas flow, whenever you are giving fresh gas flow, in order to provide, in order to avoid rebreathing, how much of the fresh gas flow you have to give, guys? Fresh gas flow should be equal to the minute volume. Minute volume is nothing but tidal volume into respiratory rate. Next is Mapleson D circuit. Mapleson D circuit is also regarded as what, guys? Bain circuit. Other name for Mapleson D is Bain circuit. Remember, B and C we are not at all using nowadays. Bain circuit. This is a circuit of choice for what ventilation? This is a circuit of choice for controlled ventilation in adults. Controlled ventilation in adults. The length of the circuit is 1.8 meters. How much is the fresh gas flow? Remember, here also in this circuit also there was a problem of rebreathing. In order to avoid this rebreathing, the fresh gases which were given to the patient were 1.6 times the minute volume. Okay, that's regarding Mapleson A and Mapleson D circuit. Mapleson E circuit. Mapleson E circuit is also called as INI-TP circuit. INI-TPs. INI-TPs यानी कि basically it's a bagless as well as a valveless circuit. It is nowadays used for weaning the patient from ventilator. Next is Mapleson F circuit, which is a modification of E circuit. Mapleson F is a modification of E circuit. modification of E circuit, which is also called as Jackson-Rees circuit. Jackson-Rees circuit. Circuit of choice for pediatric cases. This is the circuit of choice for control as well as spontaneous ventilation. Okay. So that's regarding what, guys? That's regarding the semi-open breathing circuits. Now coming to the closed breathing circuit. Which inhalational agent should be avoided with barrelime? First of all, barrelime, where it is used in anesthesia. Barrelime or soda lime are what, guys? These are the carbon dioxide absorbing materials. Carbon dioxide absorbing materials, which is commonly used in closed circuit. Okay? So which agent should be avoided with barrelime? I used to remember like this, guys. Barrelime, what is the agent that is avoided? Okay. Just look over here. Barrelime, what is the agent that is avoided, guys? Dye agent is avoided with barrelime. D stands for what? D stands for desflurane. I stands for isoflurane. E stands for enflurane. Come on, the answer should be Y. Why it is avoided? Why? Because if you get desflurane, isoflurane, or enflurane, the patient can die due to this. Desflurane will react with barrelime to produce carbon monoxide. To produce what, guys? Carbon monoxide. And maximum carbon monoxide is produced. Production can be seen with desflurane. Okay. So answer is what, guys? Remember which agent should be avoided? Desflurane should be avoided. Desflurane should be avoided. So this is the closed circuit, guys. Closed circuit means you are giving oxygen to the patient, you are giving nitrous, you are giving halothane, and the patient is exhaling this. And from the exhaled limb, it is going into this chamber where carbon dioxide gets absorbed. When the patient is exhaling, what does he exhale? He exhales carbon dioxide. Carbon dioxide is absorbed by carbon dioxide absorbing material, which is soda lime or barrelime. Coming to soda lime. Soda lime is most commonly used. Soda lime, what is it made up of? 80% of soda lime is nothing but calcium hydroxide. 16% it is water. 3% it is sodium hydroxide, and 1 to 2% it is silica and potassium hydroxide. Silica and potassium hydroxide. Which is the major component? Major component is always calcium hydroxide. But which is the main component without which soda lime is not at all, cannot be formed? Main component is always sodium hydroxide. And silica is always added to what? Is added to improve the hardness of the granules of soda lime. Hardness of the granules. Now, remember, guys, whenever you're using soda lime, some agents should be avoided with soda lime. Some inhalational agents should be avoided. What inhalational agents? The CT scan inhalational agents should be avoided. C stands for chloroform. Okay? T stands for trilene, and S stands for sevoflurane. They should never be given. Okay? Why? Because they can produce toxicities by reacting with soda lime. Okay? So sevoflurane usually reacts with soda lime to form a nephrotoxic compound called as compound A. So hence it is not given. Trilene leads to phosgene and trichloroacetylene formation. Hence it is avoided. Chloroform is not at all used nowadays. Okay. Now, guys, coming to the next thing, which is called as AMBU. When we are discussing about AMBU, what is the full form of AMBU? They won't be asking full form. No simple questions. AMBU is nothing but artificial manual breathing unit. Now in this AMBU, there is a valve which is called as pressure relieving valve, which relieves the pressure of when the pressure exceeds more than 30 to 40 centimeters of water. And this AMBU bag, there is one more valve which is called as Rubin's valve. That prevents the rebreathing. That prevents the rebreathing. That is a unidirectional valve, Rubin's valve. Okay. Now, remember, AMBU bag are of different volumes. AMBU bag will deliver how much of oxygen? 100% of oxygen can be delivered through the AMBU bag. That's regarding AMBU. Now coming to the airway devices, guys. Airway devices. Imagine if you want to secure the airway, either you can secure with a non-definitive airway, that is LMAs, or you can go for a definitive airway, that is endotracheal tube. Why I call LMAs as a non-definitive airway? Why? Because all LMAs, even though first or second generation, they will be posing the patient to a threat of aspiration. Okay. Now remember, guys, non-definitive airway devices are nothing but LMA. For short duration surgeries, we use this LMA. Now look over here. In that, we are having what LMAs, guys? First generation. When do you call LMAs at first generation? When it is having only one port, only single port LMAs are first generation. This is the classical LMA, first generation LMA. This is the flexometallic LMA. If short duration prone position surgery, flexometallic LMA. This is Cobra LMA, looks like a snake head. This is Ambu Aura 40 LMA, that is again a company name. That is again a first generation LMA. Okay? In Ambu LMA, there is Ambu Aura Gain LMA, that is the second generation. So second generation LMA means what? Second generation means it will have two ports. Two ports means one is the tracheal port for ventilation, other is the esophageal port. From that you can put the Ryle's tube and you can aspirate the gastric contents. In LMA second generation you are having ProSeal, you are having LMA Supreme, you are having LMA iGel, you are having Slipper, that is streamliner of the pharynx, you are having Ambu Gain. The thing that is common over here in second generation is what, guys? It is having two ports. Two ports means what? With second port, you can easily put the Ryle's tube. Ryle's tube can be easily put for gastric deflation. Okay. Now, guys, you must be wondering how iGel. Just look over here. iGel over here in this picture, it looks like it's having only one port. I will just show you guys. iGel is having two ports. I'm holding iGel in my hand. I'm holding iGel in my hand. Just look over here. First is the tracheal, and beside that small port is the esophageal port. Okay, that is the iGel. Now coming to the there is new generation, that is third generation LMA, that is called as Basaka's mask, which provides a seal for excellent seal for positive pressure ventilation. Again, not used commonly. Okay, other special form of LMA that doesn't have any generation is called as what, guys? It is an intubating LMA. Sorry, guys. Intubating LMA. Okay. Next, narrowest portion of the adult airway. When anyone asks you what is the narrowest portion of the adult airway or the pediatric airway, child airway, ठीक है? Will you tell them that दोनों अलग-अलग हैं क्या? Obvious सी बात है, दोनों अलग-अलग ही होंगे. ठीक है? What is the narrowest portion of the adult airway, guys? It is the glottic opening. It is the glottic opening. And what is the narrowest portion of the child's airway? It is the subglottis. It is a subglottic area. Subglottic area is the narrowest portion, right? So that was regarding a non-definitive airway. Coming to the definitive airway, that definitive airway means it is going into the trachea and you are securing the tube. For definitive airway, it is the endotracheal tube. The best way to secure the airway is by endotracheal tube. Previously, we used to use red rubber tubes, but nowadays we are not at all using. Why? Why? Because just look at the cuff size, guys. This cuff was causing tracheal mucosal injury after the surgery. Patient after surgery was complaining of severe throat pain, tracheal mucosal necrosis or injury was happening. So red rubber tube is not used. The tube that is commonly used is a PVC tube. Remember, initial red rubber tubes were what? They were high pressure, low volume cuffs. Very, very important. High pressure, low volume cuffs. Nowadays, PVC tubes are what? Low pressure, high volume cuff. Low pressure, high volume cuff. Very, very important. Very important feature, guys. Okay. Low pressure, high volume cuff. Next. What is the internal diameter of the endotracheal tube? Remember, there are many sizes of endotracheal tube, 7.5, 7, 8, 8.5. What is that? That is nothing but it's not the length of the tube, it's the internal diameter. That internal diameter determines the resistance of the tube. Resistance. Just look over here. This is the internal diameter. Just look over here. This tube I am holding. This is this is the connector, and I'm showing this is the internal diameter that determines the resistance. Now, guys, look over here. As we are talking about the endotracheal tube part, one part that we have to remember is Murphy's eye. What is this Murphy's eye? Remember, guys, endotracheal tube, if we see at the proximal part of the endotracheal tube, one opening is present at this part where he has placed his hand. Apart from that, one more opening is given at the lateral side. That is called as Murphy's eye. What is the function of Murphy's eye, guys? The function of Murphy's eye is what? It is the port that provides or it is the port or route to provide alternate ventilation. It's basically an alternative port or route to provide ventilation. To provide ventilation. If main opening is blocked, patient can be ventilated through the Murphy's eye. That's regarding the Murphy's eye, guys. Okay. Now, what is this position? First of all, guys, this position is nothing but sniffing morning air posture that is used for intubation. Okay. In sniffing morning air posture, what is he telling? Where is the extension? Cervical spine or atlanto-occipital joint? It is at the atlanto-occipital joint. The flexion in the sniffing morning air posture, the flexion is at the cervical spine and extension is at the atlanto-occipital joint. Atlanto-occipital joint. Okay. Now look over here. Apart from that, for intubation purpose, we can also use this position called as rammed position. First of all, guys, why do you use the sniffing morning air posture for intubation? Why? Because whenever you keep the patient in this posture, the oral, the pharyngeal, and the laryngeal, all three axes will be in a straight direction, and you can see the vocal cords properly. Okay. For obese patient, what is the position that is required, guys? It is the rammed up position. Rammed up position, keeping some pillows beneath the patient's shoulder. Okay. Now, we have given the position. Now we have to take an instrument that is usually used to done intubation. What is that instrument? Laryngoscope. So the question over here is identify the laryngoscope which is being used over here. Macintosh, McCoy, Miller's, or video laryngoscope. Remember, guys, a laryngoscope with a handle over here is always a McCoy's laryngoscope. McCoy's laryngoscope. Plain Macintosh will be without this blade. Okay, I'll just show you. Okay, this is the laryngoscope, guys. This is the Macintosh laryngoscope. This is the Macintosh blade. This is the Macintosh blade. The straight blade is called as Miller's laryngoscope, usually used in pediatric patients. Why? Because they have a large epiglottis which can be easily lifted through this laryngoscope. This laryngoscope, a lifesaver, which is basically the video laryngoscope. Wow. Video laryngoscope. And the next is McCoy laryngoscope. Okay. So you keep this right insertion position. Insertion position. Insertion position. I didn't get what insertion position. Okay. So anyways, for doing endotracheal intubation, guys, you take a laryngoscope in your left hand, then insert the laryngoscope from the like imagine you are standing at the patient's back, insert the laryngoscope from the right side of the mouth, deviate the tongue towards the left side. Okay. So look over here, guys. If at all during laryngoscopy, if you're not able to find vocal cords, for difficult intubation cases, we also keep this things ready. What is this called as? This is called as bougie, and this is called as stillet. Stillet. Okay. So imagine, guys, you have done laryngoscopy. You have introduced the laryngoscope and you have lifted the tongue. As you lifted the tongue, now you will be able to see what? You will be able to see the vocal cords. As you are seeing the vocal cords, based on the appearance of vocal cords, a classification is given. That is called as Cormack-Lehan's grading. That is called as what, guys? Cormack-Lehan grading. Okay. In grade 1, what do you see, guys? In grade 1, you will see the whole laryngeal aperture. You will see the whole laryngeal aperture. Okay. In grade 2 Cormack, what you will see, guys? You will see only posterior portion of laryngeal aperture. Only posterior portion of laryngeal aperture. In grade 3, what do you see? You will see the epiglottis. Okay. In grade 4, epiglottis is also not seen. No epiglottis. Okay. But remember, it's not a case of it is not an indicator or predictor of a difficult airway. Why? Because this is usually done at the time of laryngoscopy. Okay. So remember, this is called as Cormack-Lehan grading. So as I told you, guys, for intubation, just look over here. We have to keep the patient in which posture? Sniffing morning air posture. And then take the laryngoscope in your left hand, introduce from the right side, deviate the tongue, and You slowly elevate the tongue. As you elevate the tongue, you will see epiglottis. Epiglottis, you lift it, and under vision, once vocal cords are visible, pass the tube under vision inside the vocal cords. Inside the vocal cords. That's called as, that is the endotracheal intubation. Once endotracheal intubation is done, then you have to inflate the cuff. Okay. Now, guys, while placing the endotracheal tube, while you are placing it, it should be placed where? If these are the lungs and this is the trachea, where are you placing the endotracheal tube? Are you placing on the carina, or are you placing above the carina? Always remember, endotracheal tube should be placed 3 to 4 centimeters. Sorry, 3 to 4 centimeters above the carina. 3 to 4 centimeters above the carina. Then only patient can be ventilated. Patient can be ventilated in both the lungs. Okay. Now, guys, imagine you have intubated. How will you confirm that your endotracheal tube is in the trachea? I am not asking you the screening method. I am asking you the definitive test for endotracheal intubation placement. The definitive test that predicts endotracheal intubation is what, guys? It is nothing but capnograph. Capnograph is nothing but you connect the tube to a monitor that will measure the exhaled carbon dioxide. So imagine, guys, okay? Imagine you have imagine during surgery, okay? For this patient during surgery, suddenly this patient develops this kind of capnograph. Look over here. This kind of capnograph. What does this kind of capnograph means? Yani ke, first you need to understand what is a normal capnograph so that you can easily understand what is wrongly happening over here. Okay. So remember, guys, we are discussing about capnography. First, we'll discuss the normal thing. Remember, capnograph is regarded as the surest test to confirm intubation. Best confirmatory test to confirm intubation. The normal capnograph looks like this. Okay. In the capnograph, there are 4 phases, guys. What are the 4 phases? Phase 1 is what? Phase 1 is inspiratory baseline or dead space ventilation. Phase 2 is what, guys? It is expiratory upstroke. Phase 3 is what? Alveolar plateau. And phase 0 is what? Inspiratory downstroke. In between phase 2 and phase 3, an angle will be created which is called as alpha. In between phase 3 and phase 0, one more angle is created which is called as beta. Remember, capnograph is best measured at what angle? It is best measured at this angle called as beta. Best measured at beta angle. Okay. Why? Because at this phase, capnograph value is a maximum. Okay. So that's regarding the normal capnograph. The normal readings of capnograph is between 35 to 45 mm of Hg. And normal capnographs looks like this. Now look over here, guys. We'll discuss some abnormal capnographs. We'll come to the question later. Okay? Abnormal capnographs. Look over here, guys. Imagine after intubation, you get a capnograph like this, a flat capnograph. In which conditions you will look at the capnograph flat or 0 value? It is seen in esophageal intubation, or it is seen if at all you are in the, sometimes you might be in the trachea and still you might get a flat capnograph. If the patient develops cardiac arrest post intubation, he's not at all breathing, you will get a flat capnograph. Apart from that, if at all there is accidental extubation, if there is accidental extubation, then also you will see a flat capnograph. Okay? In accidental extubation, you will see a sudden capnograph value of 0. Yani normally it was going 35 and suddenly it became 0. So that is seen in this. Or so these are the conditions where you see a flat capnograph. Second capnograph is called as shark fin capnography. Now, guys, where do you see this shark fin capnography? How does shark fin capnography looks like? Look over here. Shark fin capnography looks like this. Normal capnograph was looking like this. Shark fin looks like this. When do you give the shark fin capnography? You will get the shark fin capnography when a patient is having bronchospasm. When the patient is having what, guys? Bronchospasm, where the capnograph value could be normal to high. Okay, or COPD also you might see this shark fin capnography. The third is what? Step ladder capnography. Just everyone look over here. Step ladder capnography means what? The capnograph was like this, but next value is coming like this. Next is coming like this. Yani कि step ladder, it is increasing. What does it mean, guys? It means capnograph value is increasing. It is seen in malignant hyperthermia, where the capnograph value can go up to 100 also. Okay. Next capnograph is what? Capnograph value above the baseline. I'm drawing over here, guys. Okay. Above the baseline capnograph means what? Okay. Above the baseline means what? When after intubation, you are seeing that patient is developing capnography, and it is not touching the baseline. It is starting from above the baseline. That means what? Patient is retaining his own or re-inhaling his own carbon dioxide, which could be seen in faulty expiratory valve. If the expiratory valve is faulty expiratory valve, apart from that, you can also see in exhausted soda lime. If the soda lime has exhausted, the work of soda lime is to like absorb the carbon dioxide. But if the soda lime is exhausted, you will see increase or above the capnograph value. Guys, once again, I'm repeating, this is for FMG, INI-CET and NEET PG. It will cover every, like all exams. Okay. So look over here, guys. Exhausted soda lime, you will see this capnograph, right? Next, just look over here. Next capnograph is what? Sudden fall in EtCO2. Yani ke basically the capnograph was like this. Suddenly it is falling. When do you see this kind of capnograph? Sudden falling of capnograph is seen when a patient is suffering with venous air embolism. Next is Currar notch. In the question, it was showing Currar notch capnography. The capnograph was coming something like this. Currar notch is what? It means the patient previously was under muscle relaxant effect. Now the muscle relaxant effect is gone. Patient is spontaneously breathing. Spontaneously breathing. Okay? So Currar notch indicates spontaneous ventilation. So what will you do, guys? In Currar notch, if at all you see this, what is the next step that we need to do? Come on, be fast. What is the next step if you see this kind of capnography? What's the next step? If muscle relaxant effect is gone, you have to go for what? Top up dose of muscle relaxant. Next is hyperventilation. In hyperventilation, how is the capnograph that you see? Hyperventilation, yani you have increased the respiratory rate. Due to that, carbon dioxide is washed off. So capnograph value will decrease. Imagine this is the normal capnograph. Capnograph value will decrease in hyperventilation. Okay. Next, in hypoventilation, how is the capnograph looking, guys? Hypoventilation, how does the capnograph looks like? In hypoventilation, yani you have decreased the respiratory rate. So what will happen? The capnograph value will increase. Okay. This is regarding the hypoventilation and hyperventilation. Is this thing clear? That's regarding what? Capnograph. Okay. Now guys, please solve this question. A patient was posted for scoliosis surgery under general anesthesia. For securing the airway, which endotracheal tube would be the best? Flexometallic, raised tube, double lumen tube, or normal ET tube? Come on, guys. Which endotracheal tube will you use? Come on. Very good. Remember, scoliosis yani ke spine surgery is done. Spine surgery means which is done in what position? Prone position. For prone position surgery, we cannot use a normal tube. It will kink. Double lumen tube is used for one lung ventilation. Raised tube is used for oral pathology surgeries. Raised tube is nasotracheal tube. So what is the tube that is commonly used for prone position? It is the flexometallic tube. Yani ke no matter how much you bend the tube, it won't kink. That is the flexometallic endotracheal tube. So the types of endotracheal tube that we need to remember is, this is flexometallic tube. This is what, guys? Flexometallic or armored tube, usually used for prone position surgeries. This one over here is raised tube, usually used for oral pathology surgeries. The most unhygienic. Why? Because you are introducing it through the nose, nasotracheal. If it is facing the legs, south facing. Facing the face, it is north facing. Okay. Now, 50-year-old male is posted for upper lobectomy of left lung under general anesthesia. Which endotracheal tube should be used for the surgery? Now this patient is posted for basically surgery of one lung. Surgery of one lung यानी कि basically you are giving general anesthesia to this patient. Okay, my question is, if the surgeon wants to do surgery in one lung, okay, and you are giving general anesthesia, surgeon will tell, please do not disturb this lung. You can ventilate the other lung, but do not disturb the disease lung. So what you need to do? You need to go for one lung ventilation. For one lung ventilation, guys, one lung ventilation, it is one lung ventilation. What is the tube that we commonly use? The tube that we commonly use is a long tube, which when we place, it goes into the bronchus and will ventilate only one lung. So remember, it is used for what surgeries? It is used for one lung ventilation surgeries. One lung ventilation surgeries. But after you place a double lumen tube, how will you confirm where it is? Okay, where it is, like what is the exact confirmation of it? Like, is it placed normally? Is it placed exactly or not? How will you confirm? By fiber optic bronchoscopy. Fiber optic bronchoscopy. You have to introduce a fiber optic bronchoscope through the tube and you can see the position. Next tube is called as combi tube, guys. Special kind of tube, combi tube. If you don't know how to intubate, if you don't know how to put an LMA, okay, you can take a combi tube. If in an emergency you don't have anything and you have combi tube, you must be feeling yourself as lucky. Why? Because you don't have to do laryngoscopy also. Introduce this tube blindly into the patient's mouth. Two things can happen. Either it goes into the esophagus, either it goes into the trachea. If it goes into the esophagus also, no problem. Inflate the cuff of the esophagus and ventilate through the other ports. Okay, this is called as esophageal combi tube. Esophageal combi tube. Use in emergencies where you don't know how to intubate the patient. Okay. Next thing, guys. Next airway device is called as NPA. When we are talking about NPA, what does it mean, guys? NPA is nothing but nasopharyngeal airway. Nasopharyngeal airway, exact size, how will you come to know? You keep the airway between the nose and the tragus of the ear. Exact size could be known. But it is contraindicated if the patient is having some base of skull fracture. Why? Because base of skull fracture, if you give this, what will happen? It can penetrate and go into the cranium also. So in skull base fracture, it is contraindicated. Apart from that, if the patient is having any bleeding disorder, you don't have to use this. Normally, when do you use this? If the patient is not able to breathe through the mouth. In cases of seizures, you are not able to put the Goodell's airway, you can put a nasopharyngeal airway. Okay? That is NPA. The next airway device is called as Goodell's airway. Goodell's airway is what? It is the OPA. OPA is oropharyngeal airway. The exact size can be determined by keeping the airway between the tragus of ear and angle of mouth. Between the tragus and angle of mouth. Okay, that's regarding the Goodell's airway. Now, guys, very important, guys. There have been questions nowadays asked about this. Okay, if this oxygen delivery devices, ventilators, please listen with concentration, guys. It's my guarantee you won't forget it. Okay. Now, how much FiO2 can be delivered through the below given device? So what is this below given device, guys? This is basically the nasal prawns. This is called as a nasal prawns of the nasal cannula. Okay. It will deliver how much? It will deliver 25 to 45%. But just telling the fact is not my work. My work is to make you remember this, memorize this. So guys, remember, guys, if you are in the, imagine you are in the emergency room and a patient comes to you and he's complaining of shortness of breath. Okay? Shortness of breath. When he is having shortness of breath and he will be having a saturation of 90%, the first thing what you will do is you will tell the sister that please put a oxygen delivery device to the patient. Okay? In oxygen delivery devices, there are two devices, guys, low flow and high flow devices. Low flow devices are given for mild hypoxemia or hypoxemic patient who's having a stable respiratory pattern. Then then there is one more device which is called as high flow device. High flow device is given for patient having hypoxemia with unstable respiratory pattern. Okay? So anyways, the patient came to me first. So what will I do, guys? What will I do? I'll tell the sister that I go for a low flow oxygen delivery device. It's the first device which is called as the oxygen cannula. So the sister, she is putting the oxygen cannula. Now she is asking how much liters of oxygen should be how much liters of oxygen can be given to the patient. It provides 1 to 6 liters of oxygen, and this 1 to 6 liters of oxygen will provide an FiO2 of 25 to 45%. Okay. Now imagine after 15 minutes also saturation is not improving. Now the sister is telling, sir, saturation is not improving. What should I do? You tell the sister, okay, now put a face mask, a simple face mask. She will be asking you, why, sir? Why a simple face mask now? Now you tell her that nasal prawns was giving 1 to 6 liters of simple face mask will give 6 to 10 liters of oxygen, which will give an FiO2 of 35 to 65%. Okay? 35 to 65. So basically we are increasing the oxygen, guys. But still after 15-20 minutes also sister is telling, no sir, nothing is working. Please do something. Now you tell the sister, go for NRBM. What is NRBM, guys? What is NRBM? Non-rebreathing mask. Non-rebreathing mask. How much of oxygen can we give? We are now increasing. It is 10 to 15 liters of oxygen can be provided, which will give an FiO2 of 65 to 95%. 60 to 95 or 65 to 95%. But still, after NRBM also patient is not improving. Then what we need to do? Then I'll tell the sister, now you please go with high flow oxygen delivery device. What is a high flow oxygen delivery device? Two devices are there, which is one is Venturi mask. Venturi mask will deliver oxygen at a what flow rate, guys? Venturi mask will deliver oxygen at a flow rate of 2 to 15 liters, which will deliver oxygen at, which will deliver an FiO2 of 25 to 60%. 24 or 25 to 60%. But still, remember, Venturi mask is a high flow and a fixed performance device. Fixed performance device. Whereas, if the patient is not improving, then you go for what? You tell the sister, ab bahut ho gaya, abhi aap jao, abhi you go for HFNC. What is HFNC? High flow nasal cannula, which will deliver an oxygen of how much? Which will deliver an oxygen of 40 to 60 liters, which will deliver an FiO2 of, 100%. 100%. Okay? Remember, NRBM is a variable flow. Venturi mask is a fixed performance device. So it is better than NRBM. So remember guys, this is very important regarding the oxygen delivery devices. Low flow oxygen delivery device, nasal cannula. How much is the flow rate? Please be fast. Flow rate is 1 to 6 liters. FiO2 achieved is how much? 25 to 45%. Face mask, if it is not improving, face mask. Face mask, how much of flow rate you have to give? 6 to 10 liters. Okay? And we will achieve an FiO2 of 35 to 65%. Next is NRBM. NRBM is what, guys? NRBM will be 10 to 15 liters and 95%. Maximum FiO2 in the oxygen delivery device in low flow is always the NRBM. In conventional oxygen delivery device, maximum FiO2 can be seen with NRBM. Next is Venturi mask. Venturi mask is a high flow as well as fixed performance. Okay? How much liters of oxygen are we giving over here? 2 to 15 liters. That will deliver an FiO2 of, come on, FiO2 of 24 to 60%. 24 to 60%. Okay? HFNC 40 to 60 liters, which will deliver 100% of FiO2. Now, guys, remember, regarding Venturi mask. Regarding Venturi mask. Right. Regarding Venturi mask. Look over here. Venturi mask. Venturi mask works on a one principle, guys. There are many colors of Venturi mask. So just for Venturi mask colors also there is a mnemonic. But before going to mnemonic, Venturi mask works on principle. What is the principle it works on? It works on Bernoulli's principle. Bernoulli's principle. Okay. Now the mnemonic for Venturi mask. I used to remember Venturi mask I will apply to a boy. Okay. Whenever I apply a Venturi mask to a boy, boy will often yell run girl. So boy will often yell run girl. What does it mean? Bernoulli's principle. Here. Okay. So look over here. Right. Boy will often, or boy was often yelling run girl. You have to remember in this manner. Okay. Venturi mask. Boy was often means B stands for blue color. Was W stands for white color. Okay. O stands for orange color. Yell yani ki Y stands for yellow color. R stands for red color and G stands for green color. These are the venturi mass. What is the flow rate of the venturi mass, guys? If you remember this is easy. Flow rate of venturi mass, you easily remember. It starts to 2 to 15 liters. Okay? So 2 liters. Just as you are going down, you have to add more 2 liters. So 2 liters, 4 liters, 6 liters, 10 liters. Okay? Sorry. 6 liters, 8 liters, 10 liters. And for green, you have to add more 5 liters, that is 15 liters. Okay. And how much of FiO2 it will fetch? The blue colored venturi mass will, remember the FiO2 was how much, guys? It was fetching an FiO2 of 24% to 60%. So two extremes we can remember. Okay. So remember, blue color 24. Just as you are increasing the venturi mass, you have to add 4%. So white will fetch 28%. Orange will fetch 32%. Yellow 35. Okay, red 40 and last green 60%. Green, as you are increasing the flow rate also, so it will be much increase. It will be 60%. So this is regarding the venturi mass flow. This is regarding the venturi mass flow. Okay, guys? Right. Now, imagine, guys, imagine we are still dealing with the oxygen delivery device. We are still with the patient who is in the emergency room. He is not improving in the HFNC. Remember, guys, these two masks, the high flow nasal cannula and NRBM, these two were commonly used in the COVID times. Okay, so imagine our patient who is still in the emergency. You have applied the high flow nasal cannula, still he is not improving. Then what you need to do, guys? Are you waiting for something to happen to the patient? No. If the saturation of the patient falls below 90%, even on high flow nasal cannula, that means what? You have to go for some other technique. Okay? Why? Because below 90%, the tissues become more vulnerable to hypoxia. So remember, patient oxygenation, if patient oxygenation does not improve, you have to go for mechanical ventilation. Why? Because tissue becomes more vulnerable to hypoxia if the saturation is below how much? 90%. So if HFNC is not working, then you go for ventilators. Ventilators. This topic is now ventilators. Now in ventilators, will you directly go for the invasive ventilator by endotracheal intubation? No. First you go for a non-invasive ventilation. Non-invasive ventilation. But again, there is a prerequisite for non-invasive ventilator. Remember, the patient should be having hypoxia with unstable respiratory pattern, but the main prerequisite is what? Patient should be conscious and patient should be empty stomach. Now you must be wondering, why, sir? Why empty stomach? Why? Because in non-invasive, you are keeping a mask over here and forcefully pushing the air. As you are forcefully pushing the air might undergo into the trachea as well as the esophagus. And if the patient is like unconscious, or if he is like full stomach, he will aspirate. So non-invasive ventilation, patient should have hypoxia. Okay, but he should be conscious and empty stomach. Now there are two modes in non-invasive, that is CPAP and BiPAP. So first of all, non-invasive is commonly used for what patients, guys? COPD patients, hyaline membrane disease patients. If the patient is having mild COPD, you can go for a continuous positive airway pressure, that is called as CPAP. But if the patient is having severe hypoxemia or severe COPD, for severe COPD cases, you go for BiPAP. In BiPAP, there are two modes. Remember, in BiPAP, there are two modes. One is called as the inspiratory PAP, where you are giving a very high pressure. One is called as expiratory PAP, where you are giving a low pressure. Okay, BiPAP is having two things, IPAP and EPAP. Why non-breathing? I told you non-rebreathing is a variable performance. Sometimes even though you give 12 liters of oxygen, it might not reach that much to the patient. Venturi is a fixed device. Okay, right. So anyways. So no issues, guys, no issues. Look over here, we are discussing about CPAP and BiPAP. So that's regarding the CPAP and the BiPAP. If at all the patient is not improving by the non-invasive ventilator, then you need to intubate the patient and then you have to keep the patient on invasive mode. What are the invasive modes of ventilator? Now, guys, for invasive modes of ventilators, you need to remember two things, guys. Okay, in any modes of ventilator, two things are very, very important. One is the tidal volume, other is the pressure of the ventilator. Everyone listen very carefully. You won't forget this ventilator topic. Okay, just look over here, guys. Now, so in ventilator, these two things are very important. Now, thing is, when you control the tidal volume, the ventilator will take care of the pressure. When you control the pressure, the ventilator will take care of the tidal volume. So you can control, you as an anesthetist can either adjust the volume or either adjust the pressure. But one mode of ventilator is there, that is a big boss mode of ventilator, who will tell, I will take care of all two things. I'll take care of the volume as well as I will take care of the pressure. So what is that mode called as? That mode is called as CMV. CMV is what, guys? Continuous mandatory ventilation. Continuous mandatory ventilation. Now, guys, remember, imagine our patient who was not improving on non-invasive. Now I have intubated. Now patient is not at all breathing. After intubation, he is not at all breathing. Very much labored breathing. When the patient is not breathing, you want the ventilator to take care of all the things. So the first mode of ventilator is called as what, guys? The first mode of ventilator is called as what? CMV mode. And what is the control thing in CMV mode? Are you controlling anything? No. Ventilator is telling you, I will control the tidal volume. I will control the pressure. But remember, it is basically, I usually refer it to as a Tesla car, guys. Automatic Tesla car. So anyways, look over here. It is taking care of the volume as well as the pressure. Ventilator will tell you that during, I am taking control of volume as well as pressure, but I want patient not to breathe anything. And again, there should be no triggered breathing. There should be no triggered breathing. If there should be no triggered breathing, what will you do in CMV mode? You will heavily sedate the patient. You will heavily sedate the patient. So what could be the side effect of the CMV mode, guys? Now you keep the patient in CMV mode for 2 to 3 days. What will happen? The patient also becomes lazy. Patient will tell, ventilator is generating the volume as well as pressure. Sukoon se enjoy karo. So what will happen to the muscles of the patient? Patient's muscle will develop atrophy. There will be atrophy of the muscles. So that is regarding the CMV mode. Okay. Now imagine the patient is improving on the CMV mode. Then confused? Why confused? Guys, are you clear? CMV mode is clear, right? CMV mode, basically you are the mode, this ventilator is taking care of the pressure as well as the volume. The side effect of this mode is atrophy. Come on, is it clear? Okay, so anyways, imagine after being on CMV mode, if the patient is improving, then you need to go for assist control mode. Assist control mode is the most commonly used mode for ventilation, guys. Now in assist control mode, remember, assist control meaning what? You tell the patient, you also breathe, ventilator will also breathe with you. Okay? In assist control, there are two modes, volume control as well as pressure control. When do you call a mode as a volume control, guys? Remember, when what you are controlling, when the control variable is the volume. Okay? When you are setting the tidal volume, when you set the tidal volume, ventilator will adjust the pressure. That is volume control mode. Pressure control means what, guys? Pressure control means what? When you are setting the pressure, ventilator will basically set the volume. That is called as a pressure control mode. Now, guys, for which patients you need to go for volume control ventilation? Remember, in our case, we are going because it's a step down mode. Apart from that, if at all the patient lungs mechanics are good, patient is having normal lung mechanics, he is on ventilator due to some other problem, might be CNS problem, might be some other problem, or general anesthesia. So when the lung mechanics are good, you go for what? You go for volume control mode. But remember, what is the side effect of this volume control mode, guys? Side effect of volume control mode is, as we are setting the tidal volume, ventilator will generate the pressure. So, and we are also allowing trigger breathing. As we are allowing trigger breathing, imagine, guys, this is the ventilator that is giving breath, and this is the patient taking breath. Ventilator giving breath, patient taking breath. Due to that, what will happen? There will be asynchrony. There will be asynchrony between the patient and the ventilator. And remember, as you are allowing the patient to breathe, How will be the patient sedated? He will be moderately sedated. Okay. And due to this asynchrony developing, how will be the respiratory rate? Respiratory rate increases and the patient will develop respiratory alkalosis. Okay. Apart from respiratory alkalosis, if you use this volume control mode, guys, if volume control mode is used in ARDS patient, galati se bhi you don't have to use an ARDS. If you use an ARDS patient, then what could happen? Volume trauma can happen. Volume trauma can happen. Okay. That's regarding what? That's regarding the volume control mode. Okay. Next is pressure control. Pressure control mode is what? Remember, in pressure control mode, what is the control variable? Again, it is the pressure that is a control variable. Remember, in pressure control mode, what is the side effect? Again, as you are allowing the patient to breathe in between the breaths, you are allowing the patient to breathe spontaneously and all. Here, what could happen is, sorry. Right. Right. In pressure control mode. So remember, guys, in pressure control mode, what we are doing is we are setting a pressure and tidal volume is tidal volume is generated by the ventilator. So as we are setting the pressure, what will happen is sometimes in some patients, the ventilator is not able to generate the adequate tidal volume. Due to that, what will happen? Patient will have hypoventilation. Hypoventilation. And due to hypoventilation, patient will have respiratory acidosis. Respiratory acidosis. Sir, please drink water. No issues. Okay. So remember, pressure control is used where? In ARDS patient. When the compliance of the lungs is low, you have to use pressure control mode. Okay. Now our patient is improving. Then you need to go for what? Last modes are for weaning modes. You have to go for spontaneous and pressure support. Spontaneous modes means what? Ventilator is generating the volume and giving much time for the patient to breathe. Now patient is also breathing, but still he is not able to breathe or not able to generate that volumes. Okay. So in SIMV mode, ventilator will give much time for the patient to breathe. In SIMV mode, as the ventilator is giving much time for the patient to breathe, what will happen is there is a risk of hypoventilation. There is a risk of hypoventilation. Patient not able to generate the volumes, and that hypoventilation can lead to respiratory acidosis. So remember, guys, spontaneous modes are this. So remember, CMV is the big boss mode controlling the volume and the pressure. ACMV is the most commonly used mode in ventilator, where the trigger in ACMV, what is the thing that you are controlling? In volume control, you are controlling the volume. In pressure control, you are controlling the pressure. Okay. In spontaneous mode, they are SIMV and pressure support mode. So thoda anxiety ho raha hai, jaise my third attempt, don't know, but I'm unable to move forward in life. Arey ho jata hai bhai, don't worry, don't worry. This is not the one stop, guys. There are many options. Don't get depressed and all. There are many options. Okay, give your best attempt. If you are going for FMG, give your best attempt. For NEET PG also, if you are going, give your best attempt. But it doesn't mean that you go into depression or it is the kuch nahi ho raha hai. There are many other career options and all. Right? Life is very, very important. Don't think about any negative thoughts. Okay. Right. So the question over here is, in volume control mode of ventilation, what is the control variable? Come on, guys. If you have understood what is ventilator, you will easily answer this. Chalo bhai. Very good. Guys, is everyone clear with the ventilator mode? Yes or no? I cannot repeat. You can just go through the session once again on the YouTube. But is it clear till now? Please, guys, be fast. Yes. Okay. Now, guys, what is the primary goal of PEEP? PEEP is nothing but positive end expiratory pressure. Come on, guys. What will PEEP do in the ventilator? Right? Is it increasing the tidal volume? No. It is reducing the pressure? No. It is decreasing the respiratory rate? No. Remember, guys, in ARDS patients, the alveoli are usually collapsed. Okay? And the patient is hypoxic. When you give positive end expiratory pressure, it will basically open the collapsed alveoli. It will recruit the alveoli and it will improve the oxygenation. So PEEP is used to improve the oxygenation. Right? Now, there are some parameters that we need to remember which are on ventilator, such as respiratory rate. What is the normal respiratory rate that you need to keep, guys, on ventilator? 12 to 18. But if at all the patient is having respiratory acidosis, then you can increase the respiratory rate. In case of respiratory acidosis, you have to increase the respiratory rate. Tidal volume that you give is 6 to 8 ml per kg body weight. But if the patient is suffering with ARDS, ARDS means already the lungs are in a very bad state. If you give a high tidal volume ventilation, lungs will be damaged. The compliance of lung is very low. So in ARDS patient, always you go for a lung protective strategy, which is a low tidal volume, which is 4 to 6 ml per kg body weight, or you can go less than 4 ml also per kg body weight for ARDS. FiO2, how much you keep on a ventilator, guys? 21 to 100%. But remember, when you start the ventilator, you give an FiO2 of 100% and slowly you cut down it. Why? Because you don't want oxygen toxicity. Okay? PEEP. PEEP, just now we have discussed. PEEP is nothing but positive end expiratory pressure. How much you should give, guys? 5 to 8 mm of Hg. That should be the PEEP. Now, guys, PEEP 5 to 8 mm of Hg. In which cases you need to give PEEP? When a patient is having hypoxia. PEEP will basically improve the oxygenation. It will improve oxygenation. Okay. But remember, guys, remember, PEEP is having some side effects also. We'll discuss that side effect later. Okay. PrepLadder pressure should be less than 30 centimeters, and the inspiratory to expiratory ratio in normal patient should be 1 inspiration to 2 expiration. Okay, 1:2. यानी कि one inspiratory and next 1:2 ratio you have to give. But guys, remember, when a patient is suffering with ARDS, this ratio of inspiratory to expiratory is reversed. Reverse means how much ratio should we give, guys? You are giving either 3:1 or 2:1. In ARDS, inverse ratio ventilation is the last resort for management. And you can also go for prone position ventilation in ARDS. Okay. Now we were discussing about PEEP, guys. PEEP is nothing but positive end expiratory pressure. It improves oxygenation of the patient. It prevents the atelectasis. Okay. It decreases the work of breathing, and it is used for ARDS as well as pulmonary edema. But the side effect of PEEP is what? As you give the PEEP to the patient, the venous return will decrease. That will cause hypotension. Hence, PEEP is contraindicated in patients who are in shock. Don't give PEEP. PEEP is contraindicated. PEEP can also increase the ICP. Hence, PEEP is contraindicated in neurosurgery or head injury. Okay, that's regarding what, guys? That's regarding the positive end expiratory pressure. Now coming to the most important topic, which is called as ACLS and BLS. Come on, guys. ACLS is advanced cardiac life support and BLS is basic life support. Now, in ACLS, I will give you 3 scenarios. The first scenario is what? Patient not at all. In the first scenario, there is a patient who has collapsed. In all 3 scenarios, patient has collapsed. Okay, in the first scenario, the patient has collapsed. You go to the patient, you check the pulse. Pulse is there. Breathing is there, but he's not responding. Okay. What does it mean, pulse, breathing, but if he's not responding? That means what? The patient is still breathing. Okay. So you have to keep the patient in what position? Recovery position, lateral position. Second position is second case is what? Patient has collapsed. You check the pulse. Pulse is there, no breathing. Pulse is there, but no breathing and no response. Will you start CPR? No. You remember, CPR is started if there is no pulse. If he's not breathing, just you need to give what? Rescue breaths you have to give to the patient. 10 breaths per minute or 6 breaths per second has to be given to the patient. Rescue breath, 6 breaths per second has to be given to the patient. Third scenario, you go to the patient, no pulse, no breathing, no response. That is a triad of what arrest? That is a triad of cardiac arrest. Cardiac arrest mein what you need to do, guys? Cardiac arrest mein what do we need to do? You need to go for the steps of BLS. So BLS mein what are the steps, guys? The steps that we need to remember are the SCCC, S. Come on, guys. S is scene safety. Next is what? Check response. If the person is not responding, the third step is what? Call for help. Okay, call for help. Next is what? Check for the pulse as well as breathing. What pulse are you looking for? Directly the pulse that is in line with the heart, that is carotid pulse you need to look for. Okay, and if it is an infant, you need to look for brachial pulsations. Brachial pulsations. Okay, and if at all the patient is having no pulse, no breathing, then what you need to start? You need to start your CPR. Okay, how will you start your CPR, guys? Will you start your CPR with ABC or CAB? You start your CPR with CAB protocol. CAB protocol means what? Compressions, airway, and breathing. Compressions means what? Chest compressions. How much is the chest compressions? 100 to 120 per minute should be the chest compression. Depth should be how much, guys? 5 to 6 centimeters or 2 to 2.4 inches. In case of adults, if it is an infant, then the depth of chest compression should be what, guys? 1.5 inches or 4 centimeters. 1.5 inches or 4 centimeters in infant. Okay? If it is a child whose age is more than 1 year, then the depth of compression should be how much, guys? 2 inches or 5 centimeters. 2 inches or 5 centimeters. Or in child, you can also say 1/3 of anterior posterior diameter. Okay? But whenever you are giving chest compression, always allow the chest to recoil. Okay? Now, regarding the chest compression, guys, how many compression should be given in adults and pediatrics? Compression to ventilation ratio in adults, it is 30:1. In pediatrics, in case of single rescuer, in adults and pediatrics, it is 30:1. In case of more than one rescuer in adults, again it is 30:1. In pediatrics, it is 15:2. That is the ratio that we give. In newborn, the compression to ventilation ratio is 3:1. 3:1. And if at all you have placed an advanced airway, then how much breaths you have to give in 1 minute? 10 breaths per minute in adults. Whereas basically 10 breaths per minute means what? 6 breaths per second. Sorry, not 6 breaths. 1 breath per 6 seconds. 1 breath per 6 seconds you have to give. Okay. And here in pediatric cases, 20 to 30 breaths per minute can be given if you have placed an advanced airway. Okay. Now, guys, look over here. Which of the following is the correct step in ideal sequence of effective CPR? Come on, guys. A, B, C, D. What's the answer? Compression of less than 100? No. 100 to 120. So that's not the answer. Depth of compression of 5 to 6 centimeters? Yes. Okay. Compression to ventilation ratio for adult 30:2. Wrong. Adults 30:1. Avoid interruption of less than 10 seconds. Avoid interruption of less than 10 seconds, not 15 seconds. Okay. Next. So that was the BLS. Now in ACLS, guys, advanced cardiac life support, you will be having what? In advanced cardiac life support. Sorry, guys. In advanced cardiac life support, what you will be having is there will be steps, right? If at all the patient is collapsed and all, you start CPR, and then the defibrillator arrives. Then what you need to do? Give shock. Always remember, guys, after 2 shocks, you have to give a drug called as adrenaline if the patient is having a shockable rhythm. Okay. First of all, in ACLS, remember, for shockable rhythm, the management is different, and for non-shockable rhythm, management is different. Okay. We are discussing about shockable rhythm. If the patient is having shockable rhythm, we start with the shock. And when you are giving shock, you are using a manual defibrillator. In manual defibrillator, there will be 2 modes, monophasic and biphasic. And you will always use an asynchronous mode. Okay. Monophasic, if you are giving, how much shock should be given? 360 joules. If you are giving biphasic, you have to give how much, guys? You have to give 120 to 200 joules. 120 to 200 joules for biphasic. Okay. Now, guys, look over here. If the patient is having shockable rhythm, you have to give shock. And after 2 shocks, you have to give epinephrine or adrenaline. Okay, epinephrine. When you are giving epinephrine to the patient, how much dose should be given? 1 milligram. What is the concentration of or dilution of epinephrine in cardiac arrest, guys? It is 1:10,000. 1:10,000. Very important. And this epinephrine should be repeated every 3 to 5 minutes. How will you give this epinephrine? Through the IV route. If IV is not possible, you can see in this picture, guys, how you can give epinephrine through that machine. That is nothing but IO route. Intraosseous you can give. Okay. If IO is not possible, you can give endotracheal. Okay. So remember, guys, epinephrine in cardiac arrest is 1:10,000. That means what? 1 gram of epinephrine in 10,000 ml of normal saline. Okay. In local anesthesia, the concentration of epinephrine is 1:2 lakh. Whereas in anaphylaxis, it is 1:1,000. Okay, 1:1,000. So after 2 shocks, you give epinephrine. And after 3rd shock, you add a drug called as amiodarone. You add a drug called as what, guys? Amiodarone. And what is how much amiodarone should be given, guys? 300 amiodarone. If not, in the next dose, you have to give 150 milligrams. Okay. That's regarding what, guys? That's regarding the shockable rhythm. But what if the patient is having a non-shockable rhythm? Yani if the patient is having asystole or a flat line, then what you need to do, guys? For asystole or flat line, you have to just continue CPR and give epinephrine as soon as possible and continue this epinephrine every 3 to 5 minutes. Okay? And with epinephrine in asystole or flat line, you have to rule out the 5 H's and 5 T's. Remember, guys, in case of shockable rhythm, after 3 to 4 shocks, you have to rule out 5 H's and 5 T's. Whereas in asystole or non-shockable rhythm, you have to rule out 5 H's and 5 T's as soon as possible. What are the 5 H's and 5 T's, guys? In pediatric, normally, guys, we are choosing the tibia. Okay. So look over here. What are the 5 H's and 5 T's? In pediatric as well as adults also, we are choosing tibia only. Okay. Look over here. 5 H's and 5 T's are, remember, H stands for what? These are the reversible causes of cardiac arrest. H stands for hypovolemia. Remember, if the patient is hypovolemic, he will be hypoxic. So hypoxia next. And the patient who is hypovolemic, he will be having hypothermia. Next is what? Hydrogen ion acidosis. Next is what, guys? Last H stands for hypo or hyperkalemia. Hypo or hyperkalemia. These are 5 reversible causes. Next, 5 T's are nothing but 2 T's related to heart. Related to heart are what? Cardiac tamponade. Okay, cardiac tamponade or thrombosis. Coronary thrombosis. 2 T's related to the lung. One is what, guys? Thrombosis of the pulmonary artery. Okay, यानी कि thromboembolism. Or next T is what, guys? Next T is tension pneumothorax. Last T is toxins. Patient might have cardiac arrest due to ingestion of some drugs overdose. Okay? If it is opioid, we have to give naloxone and all. Okay. Anyways, guys, this is regarding the reversible causes of cardiac arrest. Remember the chain of survival. The old chain of survival used to be like this, guys. Early recognition, CPR, rapid defibrillation, emergency services, and advanced and post care. But nowadays, guys, one more thing is added in chain of survival. That is nothing but recovery. Recovery is added. Okay. Next. Now, guys, imagine after giving the CPR and all, the patient has recovered. He has attained return of spontaneous circulation. Then what you need to do? If spontaneous circulation, yani कि pulse has come, you have to stop your CPR. And what you need to do? You need to manage the airway, keep the airway. You need to manage the airway and manage the respiratory and hemodynamic parameters. Meaning what? Try to keep the saturation between 92 to 98% and PCO2 value between normal 35 to 45%. Okay? And hemodynamics mein you have to remember, try to keep the map of the patient above 65 and systolic BP should be more than 90. Okay? After that, take a 12-lead ECG. If on 12-lead ECG, the cause of cardiac arrest was some cardiac related, then immediately send the patient to the cath lab. But if there was no cardiac issue, then you have to go for the next step, that you have to assess the Patient's alertness. Is the patient alert or not? Is the patient responsive or not? If the patient is obeying your command, then you have to rule out the reversible causes. If he is not at all obeying your command, okay, but he's not having cardiac problem, then you have to go for target temperature monitoring. Target temperature monitoring decreases the basal metabolic rate and improves the chances of survival. Okay, target temperature monitoring, you have to keep the temperature between 32 to 36, not less than that, not more than that. Then after that, obtain a CT and EEG, and then again you have to rule out the other reversible causes. This is once the patient has returned from spontaneous, once the patient has returned from cardiac arrest. Okay. Next, guys. Next is tachycardia. In ACLS guidelines, we have to also remember tachycardia. Remember, guys, I won't be going into detail. You have to just remember unstable and stable tachycardia. Remember, guys, if the patient is having unstable tachycardia, what is meant by unstable tachycardia? If the patient is having signs of instability, what is meant by signs of instability? Hasia signs. Hasia signs means what? Patient is having unstable tachycardia due to hypotension or due to altered mental status, or patient is having this due to signs of shock. Tachycardia is due to signs of shock, or I stands for ischemic chest discomfort, or A stands for acute heart failure. If the patient is having tachycardia due to Hasia factors, these factors, then the treatment is what, guys? Always remember, you have to go for synchronized cardioversion. Synchronized cardioversion. Okay, synchronized cardioversion. Okay, if the patient is having unstable tachy, you have to go for synchronized cardioversion. If the patient is having stable tachycardia means what, guys? Stable tachycardia means no signs of instability, no Hasia signs. Okay, then you have to rule out whether it is wide complex or narrow complex. Wide means wide QRS or narrow QRS. Anyways, the main management over here is what, guys? For stable tachycardia, you have to give the main management is vagal maneuver. You have to go for vagal maneuver and ABC. A stands for adenosine, B is beta blocker, C is calcium channel blocker. Adenosine initial dose that you give is 6 milligram. If not improved, then you can go for 12 milligram. 12 milligrams. Okay. Now this is regarding what? This is regarding your ACLS. Is ACLS clear, guys? Please comment over here. Is ACLS clear? कुछ तो बोल दो, मुंह तो खोल दो. ठीक है. After studying ACLS, now you are telling मेरे को सब आता है, मैं एक्सपर्ट हूं. Yes or no? ठीक है, चलो चलो, ज्यादा टाइम नहीं लेता हूं. Coming to the last topics, guys. Monitoring in anesthesia. Guys, remember, when you are monitoring, when you are giving anesthesia to the patient, you have to monitor the patient's vitals. What you are in cardiac arrest, asynchronous. In this thing, you have to give synchronized in the tachycardias. Okay. So what you have to monitor? Patient's oxygenation. Remember, guys, for monitoring in anesthesia, you have to remember oxygenation. How will you monitor the patient's oxygenation? Pulse oximetry. Pulse oximetry works on a law called as Beers-Lambert law. Absorption reflection law. Beers-Lambert law. Okay. Next, ventilation. How will you monitor the patient's ventilation? You have to monitor the patient's ventilation by capnography. Capnography is the best monitor. Okay. These are the desirable monitors, guys. These are the not desirable. These are the compulsory monitors which we have, we should have in every case. Okay. Capnography. Okay. Pulse oximetry is there. Next is circulation. For circulation, guys, you have to monitor two things. Either you can monitor by NIBP or IBP. IBP is invasive blood pressure monitoring, in which you will monitor radial artery. The artery that we choose is radial artery. If you want to check radial artery patency or ulnar artery patency before that, before going for invasive BP monitoring, you have to go for Allen's test. Allen's test can check for the patency of ulnar artery. Okay. Next, remember, in circulation, BP is monitored. Next is you monitor the ECG of the patient. Remember guys, ECG mein what are the leads you monitor? Not all 12 leads, only 2 leads are monitored. Lead 2 and lead 5. Lead 2 you monitor for arrhythmia. Lead 5 you monitor for ischemia. I'm writing it over here. If at all that is gone, you can see lead 5 is for ischemia. Okay, lead 5. Next word guys, one more monitor is done for circulation, that is TEE, trans-esophageal echocardiography. Heard about trans-esophageal echocardiography guys? You take a you take a probe through the endoscope, put that into the esophagus and take the pictures of the heart or scan of the heart. That is called as trans-esophageal echocardiography. That is best use. TEE is best used as a cardiovascular monitor when you are suspecting that the patient might land up into venous air embolism in the surgeries, like basically the surgery which is done above the level of the heart. You have to go for this. Okay? That is the sensitive monitor for venous air embolism. What are the features of venous air embolism, guys? You will see the airway pressure is high. You will see the pulse rate. How is the pulse rate of the patient? Initially, it is high, then it is low pulse rate. How is the EtCO2 of the patient? I told you guys, EtCO2 is low in venous air embolism. And you will see a murmur, guys. Okay? What murmur you will see in venous air embolism? Mill-wheel murmur. Mill-wheel murmur. So guys, remember, if अगर patient को venous air embolism होता है तो हम क्या करेंगे? You have to lie the patient in Trendelenburg position and you have to try to aspirate the air. ठीक है? Next guys, next is temperature. In temperature, what are the two things you monitor for? Core temperature and peripheral temperature. Normally for all surgeries, you go for peripheral temperature monitoring, guys. Now remember, core temperature monitoring, in core temperature, what is the commonly used site? Core temperature is an invasive. So the most commonly used site for core temperature monitoring is the esophagus. Very important, guys. Esophagus. Okay? It is a commonly used. But which is the most accurate? It is always the pulmonary artery. Why? If it is accurate, why do you use esophagus? Why? Because pulmonary artery means you have to place a Swan's catheter invasively. Non-invasive is esophagus. So in esophagus, core temperature monitoring is commonly used. Okay. Next, in the monitoring, look over here. In the monitoring, you need to look for awareness. Now, guys, awareness. What do you monitor for? You monitor for the BIS. BIS is nothing but bispectral index. Bispectral index is nothing but sum of EEGs. What is BIS? If the patient is undergoing some surgeries, you need to keep some your probes over here on the frontal lobes, on the forehead of the patient, and you need to monitor the electrical activity of the patient, whether the patient is awake or not during anesthesia. Okay. Last is what neuromuscular monitoring. In neuromuscular monitoring, there are many monitors, guys. Train of 4 monitor, single twitch. Okay. But the most common monitoring that is done is train of 4. And in the train of 4, what is the commonly nerve? What is the nerve that is being used? Ulnar nerve is used. And what is the muscle that is being used? Adductor pollicis. Adductor pollicis is the muscle that you use in train of 4 monitoring. Guys, just a brief of train of 4 so that you can get the concepts, guys. I have seen many of the students making a mistake in train of 4. Everyone look over here. Train of 4, what I do is I keep a small probe over here. I give a small electrode over here. I give 4 twitches. Okay, 0.5 in 2 seconds. I have to give 4 twitches. One twitch of 0.5 seconds. So just look over here. 1, 2, 3, 4. Okay, that is train of 4. That is normal patient. I am not under muscle relaxant. But if at all I have been given depolarizing muscle relaxant, and immediately after depolarizing muscle relaxant, you give me 4 twitches. You will see 1, 2, 3, 4. यानी कि all 4 twitches you will see of the same amplitude. Okay, all 4 twitches of the same amplitude you will see. If at all in depolarizing muscle relaxation, you will see all 4 twitches. Remember, this is in the normal patient, you will see this. If you give depolarizing muscle relaxation, you will see that there is decrease in the amplitude, but equally. So if you take a train of 4 ratio in depolarizing muscle relaxation, how will be the height of T4 by T1? T4 by T1 height will be what, guys? If you compare, the ratio will be, if this is 100, that is also 100. So the ratio will be 1 in depolarizing. But if you give me non-depolarizing, guys, just look over here. After giving non-depolarizing, what will happen? first like now you are owning the train of 4. Okay, first twitch, second twitch, third twitch, fourth twitch. Fourth twitch there is no twitch, or fourth twitch very low. So first twitch in non-depolarizing, look over here. First twitch, second twitch, third twitch, and last twitch is not coming. So remember the twitch height is fading. In cases of non-depolarizing, the twitch height fades. And how will be the ratio, guys? The ratio over here will be less than 0.4. The ratio over here will be what, guys? Less than 0.4. Is this thing clear? Sometimes the fourth twitch disappears also in non-depolarizing. If fourth twitch disappears, then the ratio will be 0. Okay, that's regarding what, guys? That's regarding the train of 4 ratio. Okay, now just look over here, guys. What is the picture of the set that is being given over here? Come on. What is this? This is a tracheostomy tube. This is a tracheostomy tube. Okay, and what is this set, guys? In this set, I can see laryngoscope. I can see the airway equipments, all airway equipment. So this will be the difficult airway or emergency airway. Difficult airway truck, difficult airway trolley, difficult airway set, basically. Okay. Next, guys, just look over here. This is what is this done over here? This is IVRA. IVRA is intravenous regional anesthesia. What is, remember, intravenous regional anesthesia is given for limb surgeries. What is the pressure in the upper limb and in the lower limb? For upper limb, you keep a pressure of 50 plus systolic BP while applying tourniquet. For lower limb, you go for 100 plus systolic BP. 100 plus systolic BP. Basically, IVRA means you are blocking the local anesthetic to go up by applying a tourniquet. That is IVRA, guys. Over here, there is EMLA. EMLA is nothing but eutectic mixture of local anesthetic. Eutectic mixture of local anesthetic, which consists of 2.5% lignocaine, 2.5% prilocaine. EMLA is contraindicated in neonates. EMLA is contraindicated in neonates. Kyun? Why? Because remember, in neonates, if you apply EMLA, what will happen? Neonatal skin can easily absorb the lignocaine and prilocaine, and that prilocaine that is absorbed can lead to a complication called as methemoglobinemia. Methemoglobinemia. So remember, that's regarding what, guys? That's regarding the EMLA cream. Okay. Now, if at all patient is having, last topic, guys, last thing, only one slide. If at all the patient is having a difficult airway, how will you manage? Very, very easy, guys. If the patient is having difficult airway, first of all, don't panic. First, give your best attempt for intubation. Give adequate muscle relaxation. Go for a good laryngoscopy. Give a great position for intubation. Okay. Plan A is you need to go for tracheal intubation. Okay. Tracheal intubation by giving good laryngoscopy, adequate muscle relaxation and all. But if tracheal intubation fails, then what you need to do? You have to ventilate the patient. Intubation is failed, then you have to ventilate. How will you ventilate the patient? Remember, in plan A, you can go for 3 attempts of intubation. If plan A fails, then you have to ventilate. If intubation has failed, at least put an LMA so that patient can breathe. Okay? Plan B is to ventilate the patient. But after putting an LMA also, imagine, guys, after putting an LMA also, the patient is not at all breathing, right? You're not able to ventilate the patient. If you are not able to ventilate the patient, again, don't panic. Go for a 2% technique. Plan C is what? 2% technique. Yani one person will be holding the mask, other person will be holding the bag, and then they will be ventilating the patient. That is plan C. If that also fails, that is a nightmare, guys. That is a nightmare. Nightmare not only for you, nightmare for me also. That also fails, then it is called as CICO. Cannot intubate, cannot ventilate. CICV, cannot intubate, cannot ventilate. In that case, you have to go for emergency front of neck access. That is nothing but you are cut opening the, like, you can go for scalpel cricothyrotomy. Scalpel cricothyrotomy. That is plan B. Okay. Scalpel cricothyrotomy. So this is regarding the main points of anesthesia, mere bhai. Okay. One more small quote before ending. If you don't sacrifice for what you want, you will become, what you want will become the sacrifice. Okay. I know these quotes are ये बहुत bland आ रहे हैं, ठीक है, but you have to concentrate, while preparing for any exam, guys, give your best. Okay. One more small thing, guys. Champions exam is there for INI-CET. Please register yourself. It is absolutely free. You can just compare your scores and all. The question paper is based on the clinical questions and the explanations. In the explanations, we are having audio explanations also. Please register yourself for the exam, guys. Okay. I hope, guys, you have enjoyed the session. I told 2.5 to 3 hours, but it was 3.5 hours. I'm sorry for that. But believe me, guys, I tried to cover most of the things that could be important for you for the exam. Okay. Once again, it is important not only for INI-CET, NEET PG or FMGE. All three exams, this session will cover. Okay. Shukriya, dhanyawad. Okay, Ashwarya, Srini, everyone. Thank you, guys. Thank you.